Elderwerks Educational Services is a not-for-profit 501c3 organization providing senior living coordination, advocacy, and education to. In many instances, our consultants serve as a lifeline or personal confidant to older adults who literally have no one living nearby. Elderwerks prefers senior housing options and providers based on you and your needs. What did you used to do? What do you do now? And what do you want to continue doing? We provide complimentary referral services to vetted supportive care providers and help families and acquaintances secure personalized living and benefit information. Our consultants are experts in senior housing of all types. We have toured the senior communities in Illinois, documenting the services, amenities, and quality of care to ensure seniors transition to the best options based on their individual. People view aging much differently than those of previous generations. Our seniors want to be connected, relevant, and celebrate life in active, vibrant surroundings. We've helped thousands of clients secure and maintain a quality of life that suits their personalities. As the population ages and demand for senior services increases, Elderwerks will be there, offering more learning opportunities, activities, fun, and support. Aging well and planning for future needs can be easy if you call Elderwerks 847-462-0885. Revere Court, dedicated memory care communities, focus on providing person-centered care and services to older adults living with dementia located in Crystal Lake, Illinois, and South Barrington, Illinois. They're the sponsors of Public Benefits and Medicare Fraud. Jesus Enriquez is the Information and Outreach Specialist for the Illinois Senior Medicare Patrol, and Joy Aaronson is Benefits Access and Information Specialist at AgeOptions. Please welcome Jesus and Joy.
Hi, everyone. Thank you so much, Elderwerks, for hosting. And we are so glad that you all are attending the AgeOptions Public Benefits and Medicare Fraud Workshop. So my name is Joy Aaronson. I work for AgeOptions in the Benefits Department, and my colleague, Jesus, will present himself after the benefits part. So we wanted to just tell you a little bit about AgeOptions. So we are the Area Agency on Aging for suburban Cook County, not the city of Chicago, the suburbs. And we serve people with disabilities and those that are 60 years and older. We serve 30 different townships and 130 communities. Our service area is approximately 573,000 older adults. So that's more than 500,000 people. In fiscal year 21, AgeOptions and our funded partners served 204,399 individuals. And our funding comes from the state of Illinois, the federal government, corporations, private foundations, and individual donations. So AgeOptions innovates, partners, and advocates to improve systems and services in order to strengthen communities so that people thrive as they age. And AgeOptions supports services and programs that make it possible for older adults to live independently in their homes and communities. So I work for the Benefits Department, and our department's goal is to increase the financial stability of older adults and persons with disabilities through several different programs. They're all public benefits programs. So just so you know, and whoopsie, we're going to just go back here. Oh, can we? Thank you. Yeah. Okay. So just so you all know, that we would really like, our department would so appreciate it if you would share this information with your neighbors, your friends, your coworkers, your people from your congregations, churches, etc. Because we want as many people who are eligible, we want to help them apply for these benefits. So we apply online for benefits. Many older adults don't have computers or the internet or feel comfortable navigating. And some of the programs require applications through the internet. And our experience is that this is so much better than paper because mail gets lost, fax machines run out of paper, etc. So in this way, we have tracking numbers, etc. So we're going to go on to the first public program that we can help people apply for. And that is called the Medicare Savings Program. Its abbreviation is MSP. And it pays for Part A and Part B of the premiums. So we could spend many, many days and hours on Medicare. And Jesus will also do a piece of that. But just to review very briefly, Part A is the hospitalization program. So for people that have worked 10 years or 40 quarters, you've already paid into that. You're not going to have to pay a premium. Part B is outpatient, and that's doctor's visits, lab fees, physical therapy, etc. So this program also covers deductibles and co-insurance. So just so you know, in 2021, the Social Security will takes out $148.50 for the Part B. So that it comes out of your Social Security direct deposit. Okay, and it's higher for people that have higher income. So this program, just so you all know, is for low income folks. So the income, and it's always gross before the Part B or taxes are taken out, is $1,098 for an individual, and with an asset limit of $7,970. Assets are things that can become liquid, like bank accounts and 401ks, etc. Does not include your home, your car, etc. Okay, so that's one program, the Medicare Savings Program, that we can help you apply for. Another program is called the Extra Help Low Income Subsidy, or LIS. So all these different benefit programs have abbreviations. So just letting you know that. So that works with coordinating Medicare Part D plans. And I always remember Medicare Part D, D stands for drugs, prescription. So it's no or low income, no or low premium and deductibles, and low copayments for the drugs. And for this particular program, the Social Security Administration processes and makes decisions, and we will be so happy to apply on your behalf. Now we're going to move on to nutrition, and we're going to talk just briefly about the Supplemental Nutrition Assistance Program. Now, this has several different names, so it might be confusing. It's also called SNAP. It's also called food stamps, and it also has something called the link card, and it's all the same. So it helps people buy food, buy groceries. That this program is for all age groups, but we're going to focus on the people that we serve in our organization, and those are folks 60 and above, or people with disabilities, or who are blind. And they need to meet the gross monthly income standards of less than $2,127 a month for an individual. And that number goes up a little bit every year, many times, or $2,873 for a household of two. For our age group and folks with disabilities, the assets do not matter, and the monthly expenses are taken into consideration. So you might ask, what are monthly expenses? Well, they're basically housing, if you rent, or if you own a home. And if you own a home, then there's other costs that go along with that, like real estate taxes and homeowners insurance. If you live in a condo, you have investment fees, etc. Unfortunately, the expenses are not, and that's a no, your car note, your car loan, or your credit card debt. And so the Department of Human Services puts all this information, how much is coming in and how much is going out for housing and also medical expenses. So they look at your premiums for Medicare, or do you have medical bills? And they put this all into a formula, and that says, yes, you're eligible, no, you're not eligible. And if you're eligible, how much in benefits you'll get per month. So just to review, this is something from the Department of Human Services. AgeOptions is happy to apply on your behalf, advocate, but we don't say yes or no, and we don't decide how much money and benefits you're getting. So now we'll go on to the next slide. So I just want to share with you and give you an image of a pie. So I really like apple pie, but you can think of any pie that you like. And I want you to know that SNAP is very different than a pie, right? So with the pie, you're going to divide it hopefully into equal pieces and distribute each piece to everybody sitting around the table. And when the pieces are gone, the pie is gone, right? That is not the case with SNAP. So this is really important, and we really need your help to get the word out, because only 48%, that's less than half, of eligible seniors are participating in this program. So for this program, if you're eligible, and you'll get the benefits. I've done a number of presentations, and I've had people raise their hands or just shout out, which is fine, and say, that's okay. I'll be all right. I can save. I can just get by. You give this to the children. They need it for their bones, etc. And I get to say to them with a big smile, you know what? The children will get this benefit, and you will also get this benefit. Okay, let's go on to the next slide. And so I just want to give you a little story. So years ago, the link card was actually food stamps, and they were coupon books. And each denomination, like $1, $5, $10, was a different color, and you would tear them out of the coupon books and give them to the cashier. So I was in line at the grocery store between two gentlemen. One gentleman in front of me was paying for his purchases with food stamps. The gentleman behind me was literally screaming so that everybody around us could hear, saying, that's just not right. You're getting government money, you're getting food stamps, you're getting steak. I can only afford hamburger. You're cheating, you're bad. And it was a very bad experience. The man paying for his purchases with the food stamps was absolutely mortified, as any of us would be. And the guy behind me had no idea what the situation was. So nowadays, it's not the coupon books, it's a card, right? And it's called the link card. It's like a debit card, and it's blue. So if you're ever in the store and you see somebody with a blue, looks like a debit card, you'll probably know that it's a link card. And the benefits, the amount that somebody gets, are deposited onto the card on a specific day of the month. And everyone doesn't get the first of the month. And then if you don't use all your benefits in one month, it carries over to the next. So if we were all together, I'd ask you to shout out, but we're not together live. So I'd like to give you like maybe 10 seconds or so. I'd like you to think about this question. What do you think you can buy with your SNAP benefits? So just think about it and say it to yourself. And then we'll go on to the next slide and we'll see what you really can buy. So here are all the things you can buy. You can buy fruits and vegetables, seeds for planting. So we're not talking about flowers. We're talking about tomato plants or cucumbers or lettuce, because for folks who have a garden, meat and fish and eggs and tofu and dairy products like yogurt and milk, bread, pasta, rice, cereal, and other grain products and ingredients used for baking or cooking, prepackaged and frozen foods, and water, juice, and ice. So I've had people ask me, can you buy chips? Can you buy like all your benefits, use it all for chips? And the answer is yes, because people are adults and there's not a nutrition link police at the door saying, oh, no, you should have spent it on something else. So, hopefully people will get healthy foods, but it's your choice. Everyone likes different kinds of foods. People have different diets, etc. So I'm going to give you just a couple seconds to think about the next question, which is, what can you not? That's a no. What can you not buy? And the answer is tobacco products like cigarettes and alcohol, any kind of alcohol. The bottom left is paper products like paper towels and Kleenex. And on the bottom right, it's hard to tell, but that's pet food. Now, in the middle, there's a rotisserie chicken. And you might say, well, hey, wait a second, that's food. But that's from a hot bar. And that usually is not an allowable item with your link card. So if you're like me and you love rotisserie chickens and you think, oh, you can get a couple meals out of it, then you need to bring some alternative kind of payment for that. Okay, so then we're just going to continue on, and you might ask, well, where can you use your SNAP benefits? And the answer is pretty much different places where food is sold. So Jewel Osco, Target, 7-Eleven, Meijer, Aldi, other stores, and sometimes in different neighborhoods. We'll just go back a second, Jesus. In different neighborhoods, you'll see a sign that says link card accepted here, and that you could use it there. Okay, we're going to continue now. And so during the pandemic, people got the maximum amount because we were in a health emergency. But many people were really reluctant to go out to the store. So they started a program with SNAP Online, so you could order online. And at the current time, there's 3 different companies that are offering that. And one is Walmart, one is Aldi, and one is Amazon. Okay, now we're going to move along and we're going to go from food to transportation. So there's something called the Benefit Access Application, and there's 2 parts to it. One is seniors ride free, and the other is the license plate discount. So the qualifications are you have to be 65 years or older or an individual with a disability and live in the state of Illinois. And the income limit, and that's always gross, right, before taxes, before your Part B is taken out, is $33,562 a year for an individual and $44,533 a year for a couple, a married couple. And that's the highest amount of income of the benefits that I'm talking about today. Now, for this program, you can only apply online. And I've given you the website, and it's a fairly easy process to do, but we are really happy to do it for you. For the license plate discount for the general public, it cost $151, and this is a $127 discount. So you're only paying, if you're eligible for this program, $24 instead of $151. Okay, we're going to keep going, talk about another program. Now, AgeOptions does not administer the Low-Income Home Energy Assistance Program, also called LIHEAP. It's administered in Cook County by CEDA. And so basically, it's to give help for people for their winter energy services. Sometimes there's furnace assistance or repairs, summer cooling if there's enough money. And basically you can contact cedaorg.net or call the Illinois LIHEAP hotline at 877-411-9276. Okay, so that's for that one. Wanted to talk about, on the next slide, just some additional resources. And one of those resources, and so we'll go on to the next slide, is called the Benefits Checkup. It was created by the National Council on Aging, and it's for people throughout the country. And this is for people 55 and older, and it screens you for over 2,000 benefit programs. And according to the website, the most recent numbers are 9 million people have participated, and they have gotten over $37 million in benefits. So you would just go on to benefitscheckup.org. Okay, the next resource to share is Medicare. And I know Jesus is going to talk about this more. Medicare, there's 2 ways to contact Medicare. One is medicare.gov, and just know that at the end of a website, gov is the US government. And on this website, you can sign up, you can change plans, there's helpful forms, there's resources, file claims and appeals, and kind of tells you what Medicare does and doesn't do. And so many people have an account, so they can look at their summary notices and see what their situation is with My Medicare. So you can go on their website, medicare.gov, and you can also call them. And that's an easy number to remember. It's called 1-800-Medicare. So you can remember that. And close to open enrollment, which is October 15th to December 7th, where people can change some of the plans. They're open 24/7, but not at this time. Okay, the next resource to share with you is called the Elder Care Locator. And it's a public service of the U.S. Administration on Aging. So it's connecting older adults and families to services. So basically, you might think, some of these different benefits that Joyce talked about, I think my cousin in Topeka, Kansas, might be eligible, but Joy's program only does benefits for suburban Cook County. So what can I do, right? So you can call them and they will give you the contact of the AAA, the Area Agency on Aging, like AgeOptions is just suburban Cook County for Topeka, Kansas, or Portland, Oregon, or any other place. And they also have other kinds of resources like long-term care ombudsman, legal services, elder abuse prevention. So 2 ways to get a hold of them are on the internet, Elder Care, all one word, eldercare.gov, or 1-800-677-1116. So 1-800-677-1116. Okay, we're just going to go on for a couple more resources. So the next one is there's some additional services for individuals with disabilities. And for people that live in suburban Cook County, there's an organization called Progress Center for Independent Living, and they have offices in Blue Island, excuse me, and Forest Park. And their number is area code 708-209-1500. So that's people under the age of 60. If you're in the city of Chicago, then another organization can serve you, and they're called Access Living. And incidentally, you can look up these organizations on the internet and just go to their websites. But I'm giving you their phone number. So Access Living is 312-640-2100. That's for the city of Chicago. And then just another resource is the Illinois Network of Centers for Independent Living. So there's a website and you can look by county in Illinois. So it's www.incil.org, and then you just click locate. Okay, so my part is almost done. So just to kind of review, there is AgeOptions that serves suburban Cook County, and our number is 708-383-0258, 708-383-0258. If you're in the city of Chicago, that's a different organization. That's the Department of Family and Support Services, Senior Services, 312-744-4016. And collar counties are outside of Cook County. So Kane, Kendall, Lake, DuPage, Will, and that's Age Guide, 1-800-528-2000. Okay, and so then you might ask in the next slide, who to contact in your community if you're in suburban Cook County. So AgeOptions funds organizations that are called the Aging and Disability Resource Networks. We call them ADRNS. And these organizations are the first point of contact to access aging services. So each organization covers a specific geographic area. So you can go to our website, services.ageoptions.org, or call us. We'd love to talk to you, 708-383-0258. And finally, go to our website. We just revised our website. It's really user-friendly. It's great. It's ageoptions.org, and you can see all the different services. And for our program, you can actually go to the benefits part and fill in some information, and then we'll call you. So my last slide is thank you so much for listening. If you want more information and a screening for benefits, for public benefits, please contact. And you can contact us through the website, emailing benefits@ageoptions.org, or call us again, 708-383-0258, extension 393, or ask for benefits. So now I'm going to turn it over to my colleague, Jesus, and he will talk about the Senior Medicare Patrol.
Joy, thank you so much. You actually were able to do the presentation 25 minutes. That's very impressive. I'm learning always a lot from you about the program as well. So with the presentation that we have here in the portion of Medicare fraud prevention, my name is Jesus Enriquez. I work with Joy at AgeOptions. As you saw, Joy demonstrated what the AgeOptions program is about and what the organization is. To protect yourselves against fraud. We do have a website. Our website is illinoissmp.org, illinoissmp.org. So the SMP program empower people on how to detect, protect, and report fraud. The SMP is also a statewide program managed by AgeOptions in partnership with 13 state agencies that serve seniors 60 and over and people who are caregivers of them. The Administration for Community Living, ACL, gives the funding to our program in Illinois, but also is available nationally in 50 states, including DC, Puerto Rico, Guam, and Virgin Islands. ACL and the SMP program have collaborations with the U.S. Department of Health and Human Services, in the United States Department of Justice, to fight Medicare fraud. So we do have a national database. If you call us and if we find that something is suspicious, we go ahead and file in the national database, and that information will be for the Department of Health and Human Services, ACL, Department of Justice, in case they determine is indeed fraudulent. So what are we going to cover? So we define the meaning versus healthcare fraud versus an error. We also talking about the importance of reporting fraud and how your community could be affected. We review examples of potential healthcare fraud. We see the COVID-19 trends and what is happening in your community, and time for questions, but this is a recording, so the questions usually will be, you might have questions, you might be able to address those questions, or if you have a case of fraud, we will provide the phone number too. So potential healthcare fraud, we say potential because we don't want to call everything fraud without you contacting your provider to rule out any error first. So potential, it's not yet fraudulent. The ACL has to deem that, but when you report that, you help yourself to protect your benefits. That's the most important thing. So fraud is billed for a service you never received or didn't receive, billed for something different than what you have received, billed for something it was not medically necessary, you got it anyways, you got a back brace and you never needed that. Billing for the same thing twice could be also a problem, a fraud. And on the other hand, errors. Errors are human mistakes, accidentally entering the wrong information or billing code, or if it's an error, not fraud, work with your clinic and your doctor to try to fix the problem. A lot of times they will help you, majority of times, But if they don't really help you, they don't want to assist you with the error, then it could be fraud. So it could be suspicious too. Now, the amount of money lost as a result of Medicare fraud. As of 2017, over $60 billion was lost to Medicare fraud, beating out the amount of expenses on any budget from Homeland Security, NIH, sponsored medical research, college Pell grants, NASA, EPA. So that's a lot of money. Every year, about the same amount of money is lost. This is just an example. 1 year, according to a bulletin board on the ARP.org, Medicare under assault from fraudsters. That's where we got that information too. So this money could be used for your community, could be used for social service programs for seniors, for example, anything. But this money is gone. So that's the essence why this program was created. We are trying to find the preventative side with seniors, you're reporting problems or avoiding problems to begin with. That has to do with fraud. So for that, take you to our messaging. Protect yourself from fraud. This is what you shouldn't do. Educate yourself, you should do. Educate yourself from fraud. Protect your Medicare card and Social Security number. Make sure nobody has a hold of them, unless it's your doctor, social worker, or government agency. Use a calendar of personal healthcare journal to record your visits and services from your doctor. Report any suspicious activity to the SMP. So you got that phone call and they're asking you for your social or your Medicare number, and you you don't remember if you give it away. Well, you can give us a call too, because that could be a suspicious activity. This is what you shouldn't do. Do not give out your Medicare card, Medicare number, Social Security card, Social Security number to anyone except your doctor or people who should have access to it. Not everybody. Do not accept medical supplies or services from door-to-door salesmen or people calling you over the phone. And we get a lot of those calls. Personally, yet I'm not on that age yet, but we're getting a lot of calls, so I can relate to that. Imagine getting calls, being at home, being, somebody that it's receiving calls from strangers and asking you for personal information. That's obviously a red flag. The best advice is to hang up and have somebody who's qualified if the call was legit. So do not allow anybody except your doctor or other doctors, providers to review your medical records or even recommend you services. You don't even know these people. They don't even know you. So all they want to do is get a hold of your information and benefits. So detect fraud. How do you detect fraud? Making sure you are looking out for mistakes and fraud. So there's something called Medicare summary notices. As Joy described, Medicare, it's a very big program, but also every 90 days or every 3 months, Medicare will send you a notice to your home listing the services you got with your doctor. If you didn't get that list of activities with your doctor, you can call 1-800-Medicare or logging into mymedicare.gov, and the number of 1-800-Medicare is on the back of your red, white, and blue card, or it's also Medicare and You booklet that you get every year, or it's also in one Medicare summary notice itself. Or if you have private insurance, you have what is named explanation of benefits. If you want to know a detailed list of services from your doctor, from your private insurance, you can also call them directly. The number is in the back of your private insurance card. Here, either is a summary notice or explanation of benefits. You're going to look at for services or equipment you never received, services or equipment not ordered by your doctor or anybody that you do not recognize, in other billing errors. Now, you might wonder, why do I have to report fraud? Why is it important? Billions of taxpayer dollars, as well as your own, are going to waste every year, like we saw before. 60 to $70 billion are lost. And the thing is, Medicare accounts for 3/4 of the pie. Medicaid, it's only 1/4. So that really gives you a big idea of the problem. When equipment is sent fraudulently and your doctor didn't have a say, it was not ordered, it might make your health with a lot worse because it doesn't fit you and nobody can guarantee it's going to work because they don't even know you when they're calling you. Your Medicare benefits might also be used up, and when you really need them in the future, it's possible that Medicare might say no to you because Medicare has a way to look that you already received the service. And unfortunately, the people that receive the service, it's a part of the scammer. So the scammer gave you that benefit and you never needed it. How do you report errors, you might wonder? If you think there might be a billing or service error by your doctor, please call the billing hotline of the provider, supplier, or hospital and try to resolve this problem as soon as you can. If the provider will not explain you or help you correct the error and you might suspect fraud, you can call the Illinois SMP. We have an information and assistance hotline at AgeOptions, a real person. So the number is 1-800-699-9043. Again, 1-800-699-9043. And it's a live person. When they answer the phone, you have to mention you need to call SMP, and they will transfer your call to a secure voicemail and we'll get a hold of you. So just so you know, that's a real person. So next, we have here some COVID-19 fraud trends and how they're happening. So we know obviously they're increasing, as well as the shots too, vaccine shots too, so as the fraud is coming up too. Scammers are targeting older adults and those with serious long-term health conditions. The fraudsters are attempting to bill Medicare for sham testing, bundle of equipments or services related to coronavirus, or not even related to it. Scams are happening through unsolicited phone calls, email, home visits, text messaging, things that you never requested before. They're coming through you. There are also social media ads and internet offerings, especially with vaccines, and prompting you to enter Social Security numbers or Medicare numbers, which it is obviously legal, it's solicitation too. So it is happening through also social media. So what can you do to prevent yourself being a victim of COVID scams? Do not give out your Medicare number to anybody other than your doctor or your healthcare provider. Protect your Medicare card number and treat your Medicare card like a credit card. Same thing with the SNAP as a correlation to this. You don't want anybody to use your SNAP benefits either. So yeah, also very important, your Medicare number and Medicare card, it is also like a credit card. Anybody that gets a hold of it can charge anything they want. And you don't want that. So you want to protect it and make sure only you have access to that. Never provide your Medicare number to anybody contacting you unsolicited, we always say, calls, texts, and emails. Unsolicited, you never ask for it. So if you never ask for that call or that person, or you don't even know this person, you don't have to provide this information. Be cautious of anybody coming to your door offering free COVID testing, treatment, supplies. And recently, they might try to be disguised as offering home vaccinations. So again, in order, for example, in suburban Cook County, if you want vaccinations at home, you can contact the hotline for Cook County vaccination hotline. So nobody will just come to you uninvited. That's my point. So again, nobody will come unsolicited. These are tips to prevent scams. Don't click on links from sources you don't know, which could put your computer or device at risk. Be cautious when purchasing supplies from unverified sources. That means sources that you don't know where they're coming from, especially online and email and phone solicitation. Again, strangers, you don't know where they're coming from. Ignore online offers for vaccines, very importantly. If you see ads touting prevention products, vaccines, or cures for COVID, it's most likely a scam, and it certainly is. Now with Medicare and COVID, Medicare Part B, as Joy was describing before, medical insurance, B as in boy, covers COVID-19 testing when ordered by your doctor after February 4, 2020. Medicare covers all medically necessary hospitalizations as a result of COVID-19, contracting that. And they also had telehealth services to enable you access your doctor without going physically to the location. You might have used that benefit. But what you might not know is that some scammers might be calling you, trying to set you up with this appointment. And they might not even know you, and they might get a hold of your Medicare number. Nobody's going to ask you to set a telehealth. You have to call a clinic and ask for that appointment. Additionally, Medicare covers the COVID-19 vaccine at no cost to you. In order to do that, in the site of vaccination, you might be asked to provide your Medicare number. You must be asked to provide your Social Security number in case you don't have your Medicare card. And that is to look your number up so they can bill Medicare, and they don't have to bill you. If somebody's trying to bill you regardless, though, that is against the law. Basically, they either bill your insurance or they treat you as somebody who's uninsured. So that's effective for Illinois. For Medicare coverage questions, contact Senior Insurance Assistance Program, the SHIP, 1-800-252-8966. And this is a program that is funded by the government. They have Medicare counselors in the state of Illinois that can answer questions with eligibility, Medicare, complex questions, or open enrollment, special enrollment periods, or even an open enrollment period in October. They can help you pick a plan or make changes to your plan. The number is 1-800-252-8966. And also Medicare.gov if you want to do the plan finder online. Now, additionally, too, you remember you need 2 doses for the shot. So it's Pfizer and Moderna. Johnson & Johnson is 1. But remember, when you receive your first dose, make sure you do the second dose so you receive full immunity. The IDPH, Illinois Department of Health, is handling COVID-19 vaccine distribution. Obviously, this site is very important because it's based on the Illinois government and IDPH. Please visit coronavirus.illinois.gov for more reliable information. Also, cdc.gov is a good website for information about COVID-19 vaccines and guidelines. We also have something that is called the Illinois SMP Program for Alerts. These are alerts sent through email every other Monday. These contains fraud-related news articles, information about scams in Illinois and other parts of the U.S., useful healthcare, and topics related to fraud. Please share this fraud alert with colleagues, consumers, neighbors, anybody in your area, and visit our website to sign up for a fraud alert email list. We will provide this during our virtual health fair in August. We'll provide this link. This is a great resource. We have about 700 people enrolled here, receiving information for free. So it's a part of through the AgeOptions website. That's how you sign up. If you or anybody would like to volunteer in our program, volunteers are the key to spreading the message. They can present, do activities, provide information, and outreach. For more information about how to volunteer with SMP, volunteer at ageoptions.org. That's the email. Or you can also call the 1-800-699-9043. If you don't have time to volunteer, which I completely understand, help us spread the word, protect, detect, and report Medicare fraud. And here we have a list of helpful resources and phone numbers that might be helpful to you in the future. The Illinois SMP, which is our program, Social Security Administration, which is very handy, Centers for Medicare and Medicaid, Better Business Bureau, Federal Trade Commission, Identity Theft Hotline to give you assistance in case of identity theft, the Elder Care Locator that Joy was mentioning too, the Illinois Senior Health Insurance Program, the counselors paid by the state and the government, 1-800-252-8966.
Yeah, we're so delighted to present to you and can't wait to talk to you.
Morning, guys.
Hi, everybody.
Morning.
Sorry we cut you off there, Joy. It was pretty rude of us. It was an accident.
All right.
We get button happy. So you've provided a lot of information for our attendees. We are going to be posting this presentation on Elderwerks website, as well as our YouTube page and Facebook page, so people can come to it later. Do either of you find anything really prevalent right now in terms of the need out there for our seniors? What are the seniors calling for most often? Tag.
That's a great question. So in addition to my job doing benefits, I'm also one of the people that answer the phones when people call AgeOptions. We have an information and assistance line, and receptionists will answer the phone as much as possible and pass it on to one of the specialists. So some of the unmet needs are transportation. That is a huge need.
I was going to mention that.
Yeah. For many of the folks in suburban Cook County, the townships, many of the townships have transportation in those buses, but it goes within the township, right? So let's say somebody has lives in, I'm just going to say Forest Park, and has their medical team is at Rush in Chicago, right? That makes it difficult. So that's one need, transportation. Housing is a huge need, both affordable housing for folks, and also for many people that live in their homes, repairs. And as people have mobility and other health issues, modifications. So those are also, and then also we get lots of calls for people that are looking for help at home and to find out that process. And we refer them to the Aging and Disability Resource Networks that we talked about, that people can, put in their community and then find out which agency serves them. So those are some thoughts. Is this what do you think?
So we have an information assistance line, but also when people call us, they can report a case, leave their phone number. So what we found is that sometimes issues calling them back because we are telling them you're not supposed to answer any call. But what I want to say is that when we read a call back will be from Miranda from area code 708. We are in Oak Park. One thing important to know is that we work with them hand by hand, step by step. This is nothing fast. This sometimes it might take several months or several weeks to resolve. And also we don't have control over those cases. So that's the federal government and law enforcement who have privacy concerns and statutes about it. Another thing that I want to mention is that we'll be getting calls where there's cases from new Medicare cards, which is basically just a recycled version about like 3 years ago when you got new Medicare cards. And they are disguising themselves as you get vaccinated, now you're entitled to a free Medicare card, which doesn't exist. Another issues that we are getting is that we're getting COVID products or we're getting COVID testing, but they are disguised as durable medical equipment. So like knee braces, that kind of thing. So it could be a combination of many. And one piece of advice I have, so everybody listening, is that please talk to your doctor. Do not accept those services. If you're always in doubt, you can always call us. If you got a suspicious call, even though your number was not compromised, you can share that experience too with us.
I agree. We always tell people that too. Sorry.
I was going to add for our benefits department also. So I think Jesus sort of hits the nail on the head, right? So we tell people, don't answer the phone. It could be fraud, etc. And then we're contacting people. But just so all the listeners know, we will always leave a message. We will always leave a message saying, this is so-and-so from AgeOptions. I'm returning your call, etc. Okay, so that I just wanted to let you all know that.
Well, I think what you said is great, Joy, that when you do leave a message, you identify yourself. I think that they should call the main AgeOptions number versus the number left on the phone, because it could still be fraud. someone to pretend to be you. I've had many people call me. I get all the fraud calls. It's quite hilarious. I'm like, please take me to jail. I'd love a vacation. I'm so rude to these people. You know, so honestly, I always tell our older adults, don't answer the phone. If someone's identifying themselves on the phone, that's fine. You can pick it up, but make sure that they're not asking for your social security number or private numbers or your credit card information or any information that what information would you ask for over the phone? Tell them what you would specifically ask for over the phone. Their name, what is it that they need to identify versus someone calling saying, I need this. So,
and you know, I think that this has been a really hard year and a half for all of us, and especially for people who live alone. You know, talking to a nice person that sounds kind of nice and interested, etc. It's been just very unfair and wrong. And these people have preyed on the loneliness.
I've got words for them.
Information.
They're not nice words, but I have words for them. If someone has a question, they can also call Elderwerks anytime. We have consultants. We don't ask for any information, period. And we will direct them to the correct phone numbers and people to speak with. We never ask for any Medicare information, credit card information, social security information. We don't care where you live. We might ask what city you're in, but we don't need your address. So we are very careful of what we capture here at Elderwerks and what we share. We do not share much unless they ask for it, right? The transportation part is across Illinois. We are having major issues throughout Illinois with transportation for our older adults. Getting to a doctor's appointments is the #1 priority, or getting to a specific like cancer center or something like that. So we've been working on this for a long time, researching it. There is not enough transportation. And I know that McHenry County, up in McHenry, they were canceling transportation through the township, which is very frustrating. I know why they're doing it. It's all politics, but to me, it's still affecting my seniors negatively. So if anyone has any better opportunities for transportation, let me know. However, they could do, I know it's not always fun. They can get a shared car through Uber or one of those. And then Lyft, didn't they have a medical transport now? I'm not sure.
I'm not aware of all this.
I know Lyft in certain units, though, they might offer vans with wheelchairs. Some Lyfts are equipped with that.
Right, and then there's also home care agencies.
I was just going to say, Jenifer, I'm sorry. I think one of the challenges with Lyft and Uber is that my understanding is it's often through a smartphone. You know, you get an app and you have to do all the information. And for folks who don't have a smartphone, it makes it hard on them.
It's very hard. So yeah, you're right. So here we go again, one big happy circle. But we'll keep working on it. Maybe someone will come up with a better solution. I know PACE is involved, but a lot of the times PACE is overbooked. Sometimes they're late. Sometimes, you know, things happen. But that is our #1 concern here right now at Elderwerks. And of course, the nutritional projects for them. We have a lot of people not eating appropriately at home. They're afraid of answering the door for food. So we need to work on that, making it a little bit clearer of how to obtain food. I know they can order through restaurants and they can get, you know, golden diners, Meals on Wheels, things like that. And they're low cost or free, depending on your ability to pay. But we're working on that as well. we don't have food here. I have snacks, but no good. Yes, we always have coffee and water and snacks that are full of sugar and sodium. So probably not good for our seniors, but it's good for my round body. In regards to repairs and modifications and help at home and things like that, the VA does have programs that do cover that for our veterans. For our seniors who aren't veterans, we direct them mostly to senior service associates, Catholic charities, and then of course AgeOptions if necessary. But are you finding it's difficult for them to get those repairs and the help at home and such? Is it hard right now to get that, or is it easier?
Well, I think the help at home the community care program has been going strong.
Okay.
And that's always, someone will call the agency that serves their community. They'll ask for an evaluation of the person, and then they will get an evaluation, see if that person is authorized to get hours, and if so, how many per day, per week. I think from my experience, in terms of the home repair and modifications, sometimes people are in old homes or homes that haven't been maintained regularly. And so to get a new roof, that kind of huge cost is really, and you don't have the funds to do it. That's a challenge.
Oh, it's not cheap. I know that some towns were offering help with repairs for older adults that were in need. There are some cities that are doing that, not all cities. So you really need to call your local government and ask if they have any programming.
I just want to say one thing here. I don't know if you're familiarized with the Illinois Assistive Technology Program. So sometimes they might ask for a wheelchair, refurbished wheelchair, or an assistive device of any kind that's refurbished or almost new. So the Illinois Assistive Technology Program can be reached out by phone, and they can evaluate what they need at no cost or no cost to the seniors too.
Oh, that's nice.
Also, yeah, that's great. And then also some of the townships do have lending closets. So essentially, like, let's say someone had a walker, they had knee replacement surgery, needed a walker, and then didn't need it after they got through their physical therapy, then that person could donate the walker or other kinds of items, and then somebody else could use it while they needed it. So that's great to share.
We do have all of the lending closets listed on our website throughout Illinois, all the ones that we found. We try to list everything. It's hard because there's thousands of things to list. We don't always find everything, but we do have all of the lending closets up there. And we also do get donations, people wanting to donate the lift chairs for homes, electronics or electric scooters. So do you ever get inquiries for those? Because we'll send them to you, because we typically don't know who needs those.
That would probably go to the lending closet.
Yeah, they don't want them. Yeah, or the medical beds, they don't want them either. They're big footprints. So, well, we'll figure it out. That's fine. So in terms of Medicare, I know we have a lot of experts at not at Elderwerks, professionals who we work with. We are not experts in Medicare. That's why we rely on you, Jesus. Do you find that most of the people that are new to Medicare are getting directed to the right products? Or are you getting calls saying, hey, this guy called me, I got my supplement through him, I think that I was overbilled? Do you ever get
I don't think so. I think that if somebody is new on Medicare, you get bombarded by a lot of publicity, by a lot of paperwork, like by a lot of things. And you don't get like the Social Security letter. They don't tell you, oh, you can call SHIP. You can call Senior Assistance Program, this number. They don't say that. And I feel that some agents might be deceiving in the messaging and things they're telling seniors. And the last research, like when it happens, is that the senior goes to another plan. Mm-hmm. So they are, not forced, but they are coerced to go to the plan. And then they call the SHIP or they call us and say, okay, you know what? I want to go back the way it was. I'm very upset. So my advice for them is please make sure your agent has a license. Make sure for the state of Illinois, make sure you are explaining your options. Make sure you get it in writing, because if you don't, and it's only a verbal statement, and make sure also that your doctors are covered and your specialists will work.
So you basically, when you're getting your supplement or advantage plan or whatever you're doing, you need to make sure that whoever's helping you is a neutral party who is dissecting what's best for you based on your prescriptions, your health needs, your location, and then puts everything in writing. And you still have choice. If you don't like that person, you can go anywhere you want.
Oh, there are thousands.
There's thousands, but be careful who you go through. Go through a broker, go through a referral, or the SHIP counselor, because we are very careful here as well. We've met some shysters. We don't like mean people or liars, so we kind of avoid them as much as possible. But
Yeah.
typically, most people that we work with, I mean, we don't work with anyone who's mean, number one. So we're very careful who we refer, but we do refer to, obviously, age options. It's important that these people are taken care of. So it's 3 months before your 65th birthday, 3 months after, correct? And then open enrollment starts October 15th.
And also the month of your birthday, so that's total 7 months. So magic number 7.
Yeah,
7.
313 is what we.
Okay. All right. So that's important to know. Are there any closing thoughts from you two before we go? Nothing.
No, we're very grateful to be included in this wonderful program. Thank you so much.
Oh, thank you. We love smart people.
I just want to say I love the new project, the virtual booth. Like I have a chance to meet cool people there.
Oh, at the Expo, at
Yes.
our online virtual world. Good. We actually, it doesn't seem that busy because it's such a large venue, but we've had over, I think, 250, 300 people on there. You just don't know because it's open 24 hours a day. So yeah, it's very, very neat. And then on these presentations, we've had hundreds and hundreds and hundreds of views. I don't even know. We'll be putting it all together later. We're just happy people want to learn and plan for their futures versus call us in crisis.
Yes,
exactly.
But anyway, thank you, Joy. Thank you, Jesus. You are both fabulous. If you need anything from Elderwerks, you know our number.
Thank you
so much, Jenifer.
Thank you both. Bye-bye. Bye.
Elderwerks Educational Services is a not-for-profit 501c3 organization providing senior living coordination, advocacy, and education to. In many instances, our consultants serve as a lifeline or personal confidant to older adults who literally have no one living nearby. Elderwerks prefers senior housing options and providers based on you and your needs. What did you used to do? What do you do now? And what do you want to continue doing? We provide complimentary referral services to vetted supportive care providers and help families and acquaintances secure personalized living and benefit information. Our consultants are experts in senior housing of all types. We have toured the senior communities in Illinois, documenting the services, amenities, and quality of care to ensure seniors transition to the best options based on their individual. People view aging much differently than those of previous generations. Our seniors want to be connected, relevant, and celebrate life in active, vibrant surroundings. We've helped thousands of clients secure and maintain a quality of life that suits their personalities. As the population ages and demand for senior services increases, Elderwerks will be there, offering more learning opportunities, activities, fun, and support. Aging well and planning for future needs can be easy if you call Elderwerks 847-462-0885. Shaw Media is the sponsor for Let's Talk About Dementia, Knowledge is Power, presented by Dr. Jenifer Wilson-Binotti, neuropsychologist with Compassionate Neuropsychology. Please welcome Dr. Wilson-Binotti.
Thanks, Jenifer. Good morning, everybody. Thank you for attending. I'll be speaking for about 45 minutes about dementia and why you should prepare for it. Let's talk about dementia. Knowledge is power. I'm Dr. Jenifer Wilson-Binotti. As Jenifer said, I'm a licensed clinical psychologist and a clinical neuropsychologist. I do evaluations, mostly of older folks. My practice is compassionate neuropsychology, and I focus mainly on the older population. However, I do evaluations of younger adults as well. Many of them have neurocognitive disorders, and some of that may include ADHD. So anyway, I visit people at home and in facilities. I am on staff at Linden Oaks Hospital, and where I mostly serve the geropsych unit. People get admitted to the geropsych unit for some odd behavior at times, some delusions and hallucinations, and I go there to evaluate for if there is a dementia process in the works. With that, dementia, so what is it? We think we know what it is, right? We hear it, now and then, and we know that it involves memory. It is here's a quiz. Is it A, a major neurocognitive disorder, B, memory decline, C, performance more than 1.5 standard deviations below the norm on neuropsych testing as compared to others, the subject's same age? Is it very scary, or is it all of the above? And this is one of those quizzes where you know from the beginning, it's all of the above, because this is an informational quiz. This is an informational question. It is all of these things. So in the psychology and medical terms, it's a major neurocognitive disorder is what it is. So dementia defined, it is a significant decline from previous level of functioning in complex attention, executive function, learning and memory, language, perceptual motor, and or social cognition. So what the operative term here is a decline from one's previous level of functioning. People can be born with these problems, and that's a developmental disability or delay. So we're talking about someone who has been previously functioning at a certain level in their lives and now are no longer functioning at that level. And we have to ask the question of why. And deficits interfere with independence in everyday activities. So there may be mild cognitive impairment, and it wouldn't necessarily interfere with everyday activities. So when we talk about the note here, it's IADLs and ADLs. ADLs are activities of daily living. Those are things like, can you get yourself out of bed? Can you get dressed? Can you shower before you get dressed? Can you make your breakfast? Can you eat your breakfast? These are activities of everyday living. Ideally, we don't need help with those things, but there are many people who do. Now, the IADLs are instrumental activities of daily living. These are the more complex things: managing your bills, managing your finances, going to the grocery store, planning for meals, those kinds of things. So we're still defining dementia. So it's and. Deficits do not occur exclusively in the context of a delirium. A delirium can look a lot like dementia, but it's very sudden. So in older folks, the most common cause of delirium is a urinary tract infection. And this will cause people with underlying dementia to be psychotic. In some cases, their behavior escalates. They become You see personality changes. They're demanding, they're paranoid, they're seeing things possibly. The first line of defense is to check all medical possibilities. Check for a UTI. There might be a metabolic problem. There might be a vitamin deficiency. There are a lot of things that can cause delirium in older folks. Now, when I said previously that people with underlying dementia generally have delirium, younger folks, like any of us on this webinar, would have a urinary tract infection. We wouldn't feel well, but we wouldn't be psychotic. Generally speaking, if you see people with a UTI and they're delirious, there is likely an underlying dementia occurring. But we're still defining dementia here. So deficits do not occur exclusively in the context of a delirium, and deficits are not better explained by another mental disorder. So here we are, we're having to eliminate things as a cause of someone's change in status. They call it at the hospital AMS, or altered mental status. So we're still eliminating possible causes for that. And so if people have underlying mental illness, such as depression or schizophrenia, then we have to eliminate that those are causing the change in status. Say someone has depression or schizophrenia and it's been controlled by medication, but maybe a change in mental status, they've stopped taking their medication, they're not organized enough to take their medication or whatever reason, then we see resurgence of symptoms of depression and schizophrenia that may be causing the change in status. So we've got to eliminate that. We have to eliminate the medical causes. So that in a nutshell is how we define dementia. Types of dementia. There are many types of dementia. The first one that always comes to mind is Alzheimer's, because that comprises 70% of all dementias. It's the most common type, and it is also the scariest for most people. There are these other dementias here. People generally retain who they are. With Alzheimer's, over time, people lose who they are, and those connected to them are not connected to them because they've lost who they are. So it's a very scary type of dementia. So Alzheimer's is the most prominent. And that is known as most commonly with, of course, memory decline and also language decline. Another one is frontotemporal lobar degeneration. This occurs most likely in younger people, and what I'm talking about is someone's 50s or 60s. And so this is a very devastating disease. And when it says lobar degeneration, you start seeing shrinkage on imaging studies in the frontal temporal areas of the brain relative to other parts of the brain. So in Alzheimer's, you're going to see generalized atrophy of the cortices, the cortex. In frontotemporal, you'll see relative to the rest of the brain, you'll see shrinkage. And you can track that over time. And that has a very different course of occurrence. You'll see different changes in the various stages of the disease. Now, at the end of just about all of these dementias, they look very similar, and they're very difficult to differentiate with neuropsychological testing. If you think about a frontotemporal lobar degeneration, it starts in the front of the brain, but then it goes to other parts of the brain. So if you're looking at it, say in the mid to mid-late stages, it's very difficult to know where it started. Unless you can corroborate it with earlier records or family background, that sort of thing. Lewy body disease, again, we see that in younger folks, not that it doesn't occur in older folks, meaning in their 80s or 90s, but you'll see this Lewy body disease occurring in someone's 50s, 60s, and 70s, early 70s. With this, there are prominent visual hallucinations. and they will see full people and people who may be passed away, and they're complex hallucinations. It is similar to Parkinson's. The timeline from onset of symptoms to end of life is a shorter timeline than Alzheimer's, as is frontotemporal lobar degeneration. Now, vascular disease, that is the second most common form of dementia, and it usually occurs with Alzheimer's, but in 10% of cases, it is a pure vascular dementia. And that you will see with changes in the frontal lobe. Neuropsychological testing can tease these apart. Now, when we talk about traumatic brain injury, you don't generally think about dementia, but if someone has a traumatic brain injury, and this can occur at any age, you may be talking about a dementia after the person has recovered to the extent they're going to recover. We see traumatic brain injury most occurs in young men in their teens, 20s, and early 30s. That's when they're, likely to act out, drive fast, get in fights, whatever. And so that's who you see with traumatic brain injuries. Substance medication-induced dementia. This, of course, occurs over time. Someone has to be drinking heavily for decades before we see a permanent status of dementia. But again, you may see this in someone's 50s, and I have. With HIV infection, of course, this takes time to develop as well. But you can see that, in people as, over decades. And then prion disease, the most common prion disease is Creutzfeldt-Jakob. And this is also a very devastating disease. It occurs in one's 50s and 60s. There's a very short timeline for this, possibly 6 months to 3 years from onset of symptoms. It's a devastating disease, very uncommon. Parkinson's disease. Parkinson's may or may not occur with dementia, and they differentiate that medically. However, it's been my experience that even those with Parkinson's disease without dementia, as the decades go on, you'll see some cognitive deficits with Parkinson's disease. Huntington's disease, over time, you'll see cognitive deficits of a subcortical type. And then due to another medical condition, you can see that with occurring with some neurological conditions or other conditions that can affect neurology. And then due to multiple etiologies, I see this a lot. I'll use that term if there's a combination of Alzheimer's and vascular dementia, or any of these other ones. You may see Lewy body disease or Parkinson's with Alzheimer's occurring at the same time. So the monster in the closet, no one wants to talk about dementia except those of us in the field, but Alzheimer's has replaced cancer as America's #1 fear. That's a very interesting change. And I speculate it's because cancer treatments overall, and for particular cancers, has really improved to the point where it's not a death sentence if you get a diagnosis of cancer. Certain cancers, it is more or less a death sentence, for example, pancreatic cancer. Short timeline, treatments are few. However, they've even improved on that. So people are becoming less fearful of that diagnosis. Now, don't misunderstand, we're still very afraid of that diagnosis. But Alzheimer's has become the #1 fear. And I think part of it is because the huge group of baby boomers is now going into their 70s. And so we're thinking about that more. Speaking of the baby boomers, the baby boom generation came about at the close of World War II when soldiers returned to the US, married, and had children. This was a very wonderful time in the country, and it was very exciting for all the men coming back. They came back, they had sweethearts, they got married, and they started having big families. And so the years are generally thought to be 1946 through 61. There are some sources that say that it extends to the year 1964, which is likely. I mean, it was a very exciting time, and I could see people having families for 20 years. And so that's a huge group of people. The earliest baby boomers are now in their mid-70s. So if you're born in 1946, this year you're turning 75. And we are developing neurocognitive disorders. That is dementia. What did I mention about some of those diseases? They occur in the 50s, 60s, and 70s. In fact, the decade of one's 70s is the most common decade of being diagnosed with Parkinson's. So, in fact, guess what? Several dementias, as I've said, more typically develop in one's 50s and 60s, like Lewy body disease, frontotemporal degeneration, Parkinsonism syndromes. Okay, so these are like Parkinson's. They're Parkinsonism syndromes, and there are three of them, and I'm not going to remember them, I know that, but one is supranuclear palsy, and I'm not going to remember the other two. They are not very common. They occur annually, one in 10,000 up to 5 in 10,000. That's not a lot. And then prion disease, as I mentioned before, that's a rare condition. But these can happen at any age: traumatic brain injury, HIV infection, and substance induced. So we're not just talking about dementia in older people. Even younger people can have dementia. Genetic testing for family members. So I have occasion to mention to family members after I've tested people and found them to have, say, early onset Alzheimer's, which is genetic, of mentioning that they may want to discuss with their doctor, getting some testing to find out if they've got it. And most people will tell me, I don't think I want to know. Now, that is counterintuitive for me, but then, you know, I'm in the field and I know that all the pitfalls that happen when you don't know and you don't plan. So people say, I don't think I want to know. Well, of course, it's frightening. And this is why they're saying that. But not knowing will not stop it. But it will make it harder in a practical sense. So why might you want to know if you have it or may develop it? To have a say while you are cognitively intact. People who just hurtle into dementia, they may be beyond having a say in what's going to happen to them. Okay, also, people in early stages of dementia can still meaningfully contribute to or make decisions. So if someone is beyond mild cognitive impairment, but say in early stages, and they still have they've retained some cognitive abilities, they can still meaningfully contribute to what happens to them, what happens to their money, how they want to spend their money, what's important to them moving forward. So family do not have to guess what you would want. That's something very interesting with my husband. There was someone that we knew who had developed a serious heart condition. They had diabetes and they were unconscious. And the doctor said, we need to amputate all the arms and legs. Yes, I know. So now we're all gasping. And the wife approved that. And because if they did not do it, her husband would have died. And she approved that surgery. And to me, it would be, I would never want that for myself. And I assumed that was the case for my husband. And I asked him, he said, well, of course I'd want you to have the surgery. That was a big surprise for me. And so you may think you know what your spouse or your parent or your sibling, aunt or uncle would want, but you may not know what they would want. Of course, after I said to my husband, well, we'll see what happens. Okay, so you want to unburden your loved ones from having to make those difficult decisions. So dementia is as much a weight on family as it is on the sufferer. And in some ways more, but I think in many ways it's more, because they're relieved of having to make decisions. And there you are, with them behaving erratically, being verbally cruel because they can't help it. They're accusing you of not loving them, stealing their money, so on and so forth. They don't understand what's happening. And there is some semblance of peace when you know that they have pre-designated what they want you to do. You really want to unburden your loved ones from having to make those decisions. They have to worry about your safety, your nutrition, medications, health conditions, finances, well-being, and contentment when you're not able to do so for yourself. What we see when people are moving into dementia as it moves along, they lose safety awareness. And that even includes, well, I'm not going to use my walker because I don't need it. Well, they don't know that they don't need it. They don't know what they don't know. They are very often, they've stopped eating for whatever reason. And they continue to feed the dog many times a day because they've forgotten that they've already fed the dog. When I go to someone's home and I see a very undernourished person and a big fat dog, I have pretty severe, significant concerns what's going on with that individual. And then of course, then that's contributing to their decline, their cognitive decline, because they are not eating. Now, there are different reasons that people stop eating. One is they simply lose appetite. With Parkinson's, for example, that is part of the autonomic system where you naturally become hungry at certain times, in certain patterns, and to eat. This is affected with Parkinson's, so they don't know to eat. And in fact, then if someone puts a meal in front of them and they eat a couple of bites, they feel early satiety because it's not regulated appropriately. And so they feel full after 2 or 3 bites. Well, of course, they're going to lose weight. So that requires a nutritionist and, a certain structure and regularity to their meals, whether they want them or not. So also medications. People stop taking medications. They think they don't need it. They think they've taken it already. They double up on it because they think they haven't taken it. I went to someone's house once and they could not tell me what medications they took or what their status was, if they needed to be filled or not. And I said, well, where are the bottles? Because I'll go and look at the bottles and copy them down. Well, he said, well, I don't keep them in the bottles. And he pointed to a bowl in the middle of the kitchen counter where they were all dumped from the bottles into the bowl. Now we're talking about a Halloween candy bowl is what it looked like. So that was very alarming. Don't think that doesn't happen. It happens much more often than you think when there's a dementia that is setting in. And people can be very difficult about it. Some people, paranoia is very common with dementia, and they don't want to take the medications because they think they're being poisoned. They think that someone's trying to poison them to take their money. They think that someone wants them to die. And so all kinds of stories get whipped up in their minds. People have to worry about your health conditions. There are many health conditions that need to be managed on a daily basis. One of the health conditions that is common with dementia is diabetes, and that needs to be managed every single day, both with diet and medication. It has to be monitored. Blood sugar has to be monitored. And there are other conditions as well. Hypertension, you've got to take your medication every day. Finances. Okay, so it's such a tragedy to me when people have lost thousands, tens of thousands, hundreds of thousands of dollars to scams. Okay, I can't tell you how many times I've been with people, their phone rings, and I can tell by the conversation that it is a predator, a financial predator on the other end of the line that's trying to get the person to divulge personal information. And they do it all the time. And I have worked with people who've lost hundreds of thousands of dollars, and that they now have diminished resources for their care that they need. It's tragic. It really is. People, your family has to worry about your well-being, just overall. Are you getting what you need? Are you content? Is your life the best quality it can be? And so the people who care about you, they worry about those things. You can plan for these things. So what does it mean to be decisional? Okay, people, it can be a very fuzzy line when someone goes from being decisional to non-decisional. It can be a very fuzzy line and cause a lot of problems. 4 conditions must be met. Now, by the way, I test for this. Neuropsychological testing, this is one of the referral questions is this person decisional? Does this person need a guardian, or has this person already designated a power of attorney for healthcare and finance? So what does it mean to be decisional? In the state of Illinois, 4 conditions must be met. All 4 of them must be met, okay? If one is missing, they are not, okay? So the person has to have the ability to understand their illness and or treatment and or prognosis and or finances, etc. They have to be able to understand what it means. So you sit down and you say, now you have, okay, diabetes. What does that mean? What is that illness? What does that mean? Not only when were you diagnosed, what does that mean? What does it affect? What activities that you do or don't do affects it? Okay, so that's one of the things. What are the treatments? What has your doctor prescribed? Do you understand the medications? Do you understand the doses, frequency? What is your prognosis for your health conditions? Your finances, okay? You manage them. What does that mean to manage your finances? Do you understand how much money you have? Do you know how much it takes to live? So on and so forth. The second one, do you have insight into it? Do you understand what it means if you don't understand it? Can you explain to others the ins and outs of it? What would happen if you made this decision or that decision? You have to have an ability and willingness to express a choice. In Illinois, if you don't have a willingness to express a choice, you are deemed unable. You are deemed non-decisional. You have to have a willingness to express your choices. Believe it or not, I've had people unwilling to express their choices. Able to, but unwilling to. Then there has to be the ability to understand the consequences of choices. This is a frontal lobe function. This is a complex function that is readily diminished with even minimal changes in the frontal lobe. We see an inability to understand consequences of choices in younger people with certain conditions. You see, say, a young man, it's more often it's males who have had a frontal lobe brain injury, and they don't understand that if they get drunk and get in a fight, they're going to have maybe a broken jaw for one, but they could have a legal record. They don't understand that if they drink and drive, they could have their license taken away. They just live in the moment. Okay, so people have to have an ability to understand consequences of decisions and choices. If you do this, what might happen? They have to be able to explain that. So these are the 4 conditions that have to exist. Dementia quickly erodes and diminishes these abilities. In early stages of, say, we're talking about Alzheimer's, working memory, and I'm going to explain that in a little bit. Working memory, quickly, it's an early diminished ability. And you need to have that in order to manage your finances and bills. And so we see that, we see problems with bills. All of a sudden your dad, who's never been late, never gotten a pink slip in the mail, is all of a sudden getting his lights turned off. Well, something is happening. What exactly diminishes? What are the abilities that diminish? These are the things that are tested for with neuropsychological evaluations. Of course, memory, short and long term. Short-term memory, what'd you have for breakfast? Short-term memory, who'd you see yesterday? Did your son or daughter visit yesterday? You know, there are a lot of, not a lot, but there are some people whose Alzheimer's has evolved to the point where they don't remember their kids visiting or calling, and they sit there and they think that their kids haven't come for, you know, months and months. And of course they believe this, and this leads to feelings of abandonment. So you want to do things like send cards or send recordings and say, Mom, I'm thinking about you. Remember yesterday visit, or you know, whatever it is, so that they have something in the moment to let them know you're thinking about them. So these are creative solutions to some of this. Memory diminishes. And then as I was talking about, working memory diminishes early because that's a frontal lobe function. Our frontal lobes are very sensitive to cognitive changes because it's the latest one to have evolutionarily developed. And so the vessels in the frontal lobe are small and fine, and they're the first to diminish in with certain dementias. And Alzheimer's, that is one of the earliest signs, and it's usually mild to start with. But what it is the ability to hold something in your attention, in your operational memory, and then manipulate that information. And when you want to think about, say you go to Mickey D's and you order a $1 meal and you hand them a $5, well, you're doing the calculation in your mind. You're holding how much it was, how much you gave them, and then you're doing the calculation to know how much you should get back. That's working memory. One of the tests that we do is you give them a series of randomly ordered numbers, and you say, now repeat those numbers forward. Okay, so that's a basic working memory, and then repeat them backward, and then order them and tell them to me numerically from smallest to largest. That is working memory. It's a tricky task. And then you give them longer and longer series of numbers, and you see where they top out. And of course, naturally, as we get older, we top out at shorter and shorter series of numbers. And so we compare it, though, to other people your age with normal functioning. And that has to be taken into consideration during testing of someone. What else diminishes? Reasoning. There are different kinds of reasoning. Nonverbal reasoning. Okay, this is not talking, this is looking at pictures, figures, so on. So one of the tests we do is you look at a series of figures, and you choose from a series of 5 the most logical picture to go with the other ones to complete a pattern. That's nonverbal reasoning. So say you have 2 bars and a circle and a question mark. And in the choices, there's another circle. That's the one you would choose. Well, of course, among them is another bar. There are many people who would stick a 3rd bar with the other 2 in the circle. and that makes sense to them. But you want to balance the pattern, so you'd want 2 and 2. That's nonverbal reasoning. Abstract reasoning is verbal, and it's where you abstract concepts. So in the testing, you would give them 2 similar terms, and they're to abstract what they are. For example, ice cream and pie could be said to be both desserts, or they're both sweet. That's how you abstract. That's abstract reasoning. Simple and complex processing. Complex processing is a frontal lobe function that is also very sensitive to cognitive changes. Complex processing would include something like, let's see, I want you to alternate between countries in the world and animals. That comes from, you pull that information from different parts of your brain. It's very complex because you have to stop thinking about countries each time to start naming animals, an animal. And then you have to stop naming animals and go back to countries. So you alternate between the 2. That's hard to do. You go Brazil, cat, Colombia, dog, North America, elephant. That's very complex. So that's complex processing. Language is a cognitive function that diminishes, particularly with Alzheimer's. Also, if there's a stroke in the language area, we've all heard about someone who's had a stroke and there's been a change in their communication abilities. So we have expressive language. This is like what we say. There are different kinds. One is where we can name objects, like I was just doing with countries and animals. There's also expressive fluency. So you would, for example, name all the animals you can think of. That's semantic fluency. There's phonemic fluency, where you say, tell me all the words that you can think of that start with the letter S. And so that's phonemic fluency. There's receptive language, so hearing and reading. These are all different parts of language, but they diminish, and they may diminish at different rates, depending on the dementia process. Visual, perceptual, and spatial abilities, they diminish as well, and you'll see differences in testing depending on what kind of changes have occurred. So these are the abilities that diminish and can affect how a dementia presents or how decisional a person is. So what is affected by these abilities? Memory, like only everything. This is so important, and this is why it's so devastating to lose it. How can you track your life from minute to minute or day to day when you are losing your memory? You simply become living in the moment. Working memory, you need that for finances, medication management, cooking, all kinds of things. Reasoning, nonverbal and abstract, you need it for decisions, communications. Simple and complex processing, finances and healthcare. Language, expressive and receptive, understanding verbal and written information and expressing your wishes. And then visual, perceptual, and spatial, driving and walking, getting around. This is one of the reasons people are tripping and falling when they have dementia. Testing is particularly important for visual, spatial, and perceptual for driving. So there are 3 components I look for with an Alzheimer's. One is their short-term memory deficits for driving, their visual spatial changes, and then also processing speed. How fast are they able to process information? If any one of those is missing, you better not be driving. You shouldn't be behind the wheel because you have your safety and other safety in your hands. Now, this is a tough thing because people feel diminished as individuals when their privileges are taken away, or their rights, freedoms, whatever you want to call it. But here's the thing, driving is a privilege. It's not a right. Driving is a privilege. And if you're a danger to anybody, you should not be driving, period. Is someone non-decisional? Do they lack capacity, in other words, or are they incompetent? People get these terms mixed up, but incompetence is a legal term. I'm going to read this quickly. The term incompetence describes any person who, because of insanity, mental illness, mental retardation, old age, physical incapacity, imperfection, or deteriorating mental ability, or is incapable of managing his person or estate, and any person who, because of gambling, idleness, debauchery, or excessive use of intoxicants or drugs, so spends or wastes his estates as to expose himself or family to want or suffering. This is a very old definition, but basically this is what it comes down to. That's what incompetence is, but it is, as I said, a legal term. I don't use incompetence in my reports because I have no say-so legally. I use the term non-decisional or someone lacks capacity. Neuropsychologists, like me, assess for decisional capacity, not competence. This is an important differentiator. What should I do to prepare? Okay, we're winding down a little bit here. So the good reason to know if you may develop it or if you have developed it early enough to take care of these things, you should appoint someone you trust to make decisions on your behalf when you are not able. I've appointed my husband. I've made it clear what is important to me. And I've appointed my sisters as the runners-up. You make and document a plan that is feasible for your financial circumstances. Not everybody can go to the Palmer House in your later years. And you want to be able to fund your dementia, so to speak. Prepare a living will. Do not resuscitate. Do you want, if you have a heart attack, do you want people to go to Herculean measures to bring you back or not? Do you want a feeding tube? This is very tricky. Once you get a feeding tube, it's hard legally to remove it if someone doesn't want it removed. You really need to think about these things. Plan ahead and check your plan annually because your circumstances may change. Your values may change. You may want something different as you get closer to this time. Establish a trust, a will, estate, etc. See an elder care attorney for these things. Don't do it online. Don't do it with forms. You need someone who is going to eliminate any loopholes, any possibility for someone who may want to exploit a loophole that may come along. Clarify your wishes for disposition of assets and discuss with all of those involved. You don't want to do it where, oh yeah, you've designated someone and then you haven't told them. Like I told my sisters, they're the runners-up in the beauty pageant. You may not be able to stop the dementia train, but you can make the ride less bumpy for everyone. This is very important to remember. Okay, and now is time for questions. I thank you very much for your attention.
Hi there, Dr. Binotti. How are you?
Good. How is everybody there?
Praise. We might need some help soon. Our brains are full. I love your presentation. I actually listened to it, which is, I'm a squirrel.
I actually listened to my own.
So listening to the ending, it's, you said review your plans with whoever you're assigning. I have had people contact me and say, oh, I told the attorney to put my sister in to make my decisions. She's the power of attorney for healthcare, but didn't tell the sister. And I'm like, is your sister capable? Will she make the decisions you want? I don't know.
Yeah, I had to be careful about the sisters I picked.
I don't know how many sisters you have. I have one. My sister has appointed me executor, power of attorney for everything, and I'm like, please last a long time because that's
absolutely.
It's so stressful. It's a very stressful job, and the thing that people need to understand is being a power of attorney or healthcare or a property or the executor, they're all very stressful duties.
They are. And they're bigger than people think.
They're the fiduciary. They are the ones that need to make the decisions you'd make for yourself.
Absolutely.
So if you're assigning someone who has maybe some cognitive impairment, or you have an old will and trust and POA docs and your legal docs are ancient,
Yeah,
and your family was fine until now, you might want to review them, right?
that's right. That's why I said to do it annually. That my sister recently made a few changes, and it was appropriate. The changes, you have to think about it every year, and you should set a date to annually look at your plan, because say you have an older sibling that you have appointed who has started to slip a little bit, you may want to make some changes. In fact, you will want to make some changes.
I would assume so, but we can't make people do what's right.
Yeah, that's
I
right.
think people they do everything. They're like, I'm set. They put it on a shelf and they don't look for it 10, 20 years.
Yeah, exactly.
Which I am guilty of, just so you know. I think it's about time I update them. I keep talking about it. I will update them, but So in regard to dementia, I know you said you need to talk about it and discuss it, and I agree with you 100%. Putting your head in the sand is not a good thing to do.
Right.
Do you recommend if someone has dementia or Alzheimer's in the family that they work a little bit faster and harder, or what are your guidelines on that?
So if there is someone in the family who has dementia and nothing is in place, is that what you're asking?
Yes.
Okay, so I see this all the time. And so first of all, we need to understand what the person is capable of. How far along is their dementia? What kind is it? Are they able to contribute to decisions? Because decisions would have to be made now. What type of care do they need? To what extent? And so we're talking about something as minimal as, say, having medication management, which is usually one of the first things that I recommend.
Right.
Up to because they are so disoriented that they're wandering and leaving the home, that they need to be in a secure facility. So there's a whole range of possibilities, and we need to narrow that down. So we need to define what we're looking at, where are we at this point in time.
I think isn't it mostly a safety issue at that point?
It's a safety issue at every point. So the two factors that we weigh, the two overall factors, is safety and independence. Okay, we do not want someone's independence to be taken away before it's time. Okay, and we're talking about different aspects. Driving is one example. Being able to manage their own finances. We don't want these to stop prematurely. Okay, so we need to find that line where they're at, they're safe, but there's independence. We've optimized their independence. Now, this is a moving line, and so that's why it has to be monitored. Of the two, between safety and independence, safety is number one.
Right.
And so that has to be considered first, with independence second.
And what about those who, so this happens all the time, I know, and it's very hard for us here at Elderwerks. We have a loved one who's taking care of the person with cognitive impairment, whatever level they're at, whatever disease they've got, and they want them to stay home as long as possible. I don't know why. I don't know if it's because the person with cognitive impairment requested that previously, or it's just the guilt factor, or what. What are some things you can tell our at-home caregivers to think about before saying, I'm going to take care of this person forever? I mean, it's killing some people, and it's not.
It is. I mean, research shows that very often the caregiver will die first because they have run themselves into the ground. I want people to understand that caring for someone with dementia, particularly in its later stages, is like caring for a toddler. Okay, especially if they're mobile. And it is extremely taxing, number one. Now, number two, here's why to consider a community. People decline slower, and this is research, when they are socializing with others.
Yes.
And when you go to a community, you are with others.
100% agree
And
with that.
absolutely. This is a huge thing. I understand why people would like their loved one to stay at home. I understand that. But as they go into dementia, they need to be socialized more. That is the one factor of all the factors that weigh in on dementia. That is the one factor that they show consistently is helps to slow the decline. Okay.
Yeah.
And also, when you have someone, in a community, they've got eyes on that person. They've got eyes on the person, all day long, depending on their level of care. And the person has access to being assisted. They have a button to press. People will come right away if they've fallen, that kind of thing. Can't get off the toilet, whatever.
Well, everyone has family members with some sort of issues. So here's an example of a couple I know personally.
Mm-hmm.
I should stop giggling. It's my own personal hell. So these people live at home independently. They have great neighbors, wonderful neighbors who check on them and help them with the maintenance outside. And the one person falls regularly, does have cognitive impairment. It's minor at this point. Has some medical issues, is on a lot of medications. And the other one is mostly well, but is now also getting some cognitive impairment due to lack of socialization. Definitely lack of socialization. And they want to stay home because, number one, they're afraid of change. I'll guarantee you they're afraid of change. They love their house. They love their neighbors. Cool. So your neighbor's coming over and playing canasta with you. Are you enjoying their time and company, or are they just helping you with the maintenance? Because that's not living. So what would you give? And they aren't going to listen to me because why would they, right? So my question to you is, what would be your recommendation for a couple like this?
Oh, yeah. Here's the thing about it. Their neighbors, as wonderful as they are not accountable.
Correct.
They're not accountable to anybody for it. And as I see so often that the people say, oh, the neighbors check on me a lot. Yeah, but you know what? The neighbors don't understand dementia. Unless you've got someone like Jenifer Prell next door or Dr. Wilson Binotti next door who understands dementia and what happens, they don't understand the pitfalls. They don't understand that, confused Mrs. Smith next door is on the verge of wandering because she's regressed back in time to the point where she thinks she has to go to school. Mm-hmm. And that's why she's leaving the house and wandering. Has no idea where she's going. That it's an accident waiting to happen. And that's what I say. You are tempting fate. You are tempting fate. You don't know. And the more intact partner, they're losing track of how impaired the spouse is,
right?
Because they live with that person every day, and so they're accommodating to that person.
True.
And so they're losing track of how declined that person really is. Yeah, and testing is like a flashlight.
Yes, except for when the testing is done by a party that is not you. Let me put it that way. I can't mention the organization, but because I'll get in trouble. I have to watch. I always stick my foot in my mouth. I have to watch this. I'm being very politically correct right now. Say there's no issues.
Let me explain about that. There's no issues. Okay. So those screener tests that are done, and there's endless numbers of them out there. You hear, MoCA, MIMSI, blah, 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 blah. They're wonderful for the purpose of screening.
Right.
Screening. And that means if you see something that pops up on that, you need more evaluation. Okay. Now, let me explain those tests. They do a little teeny memory test, and they do a little teeny clock. And they do a couple of animals and that kind of thing. It doesn't give enough latitude for the impaired person who is only perhaps mildly impaired to actually make the mistakes.
Right.
Okay? And so you have to give them room to make the mistakes if they're there. And that's why it's not sensitive enough.
Mm-hmm. I agree 100%. And also they're testing when this person is fully cognitive. It's first thing in the morning. We're wide awake. That's not how it is at the end of the day.
No, that's right. That's right. And any, you can't, a lot of people say, or families or whatever they say, but they do so well early in the day. And I say, you have to consider this based at their worst, because that's when the dangers come in.
Right.
And if the second half of the day is the worst for this person, that's how you have to base the treatment that you prescribe.
100%. And that is something that Elderwerks always says when we are working with families. We say, if you're going to go get tests anywhere, make sure it's when they're at their worst, not when they're at their best.
Yes, absolutely.
Because they can totally fool the doctors. Because they
can fool the doctors, yes. Mm-hmm. Yes, they can. And they fool families. They fool a lot of people. Now, even I actually like to test people at their best, because I'm going to find it. I'm going to find something going on, but I'm also knowing that they're doing the best they can.
Right.
So,
maybe I should send them to you.
Say again?
I said, maybe I should send them to you, but I'm guessing they won't go.
Well, and that's another thing. I actually went to a woman's door yesterday in a community, and I know there's an Alzheimer's going on just based on what I'm hearing. And she says, no, I don't think so. I don't think you can help me with the cybersecurity team that's after me. It's like, okay. And then she closed the door. It's like, okay. But my responsibility at that point was to advise the community, this is probably what you have, and this is what you need to look for. And we need to, alert her powers of attorney that something is going on. So
do you go to communities regularly to assess folks?
I go to communities, I go to people's homes. And then I'm on staff at Linden Oaks Hospital.
And how far out do you go?
I go all over. I've really had it with going into the city. So I'm not going into the city because of, parking and the hassles and.
Oh, I know.
But I do take it on a case by case basis. So, but yeah, and I'd rather see people in their own environment, because I can glean a lot of information that way. Mm-hmm. How does the person live? Are they in a hoarding situation? Is the house dirty? Are they dirty? If I'm in an office, their family's going to clean them up and shower them and put clean clothes on them. I'm not seeing that aspect of it.
Right.
So I like to see them in their own environment.
That's very good advice. I know that a lot of docs don't do the traveling. Mm-hmm. That makes more sense to me, because I think when they're doing a special occasion and they're getting dressed and they're showering, they're on their best behavior.
You bet. You don't see it.
Nope. And it happens here too. We have people brought in to Elderwerks Center, and they look fine to me, but I talk to them and I know.
Right. Exactly.
It's different. Exactly. We need to work on our communities and the community involvement with those with cognitive impairment. I know there's a lot of dementia-friendly cities. We need that throughout the whole state. Honestly,
Absolutely.
Every state should have this. So we can support those with cognitive impairment so they can live in the community longer, but also when people notice these things, they can make sure that person is safe.
Absolutely.
Yeah.
Absolutely.
Do you have any final thoughts before we go, Dr. Binotti? I know you're busy beaver.
I really, really am. I just, welcome anybody that has any other questions. They can contact me. I'm sure you have my information, and I'd be glad to answer any other questions.
All right. Well, we'll definitely direct those that have some questions to you. Thank you so much for everything you do for us. We appreciate it.
You're welcome.
Thank you.
Okay, thanks.
Bye.
Elderwerks Educational Services is a not-for-profit 501c3 organization providing senior living coordination, advocacy, and education to. In many instances, our consultants serve as a lifeline or personal confidant to older adults who literally have no one living nearby. Elderwerks prefers senior housing options and providers based on you and your needs. What did you used to do? What do you do now? And what do you want to continue doing? We provide complimentary referral services to vetted supportive care providers and help families and acquaintances secure personalized living and benefit information. Our consultants are experts in senior housing of all types. We have toured the senior communities in Illinois, documenting the services, amenities, and quality of care to ensure seniors transition to the best options based on their individual. People view aging much differently than those of previous generations. Our seniors want to be connected, relevant, and celebrate life in active, vibrant surroundings. We've helped thousands of clients secure and maintain a quality of life that suits their personalities. As the population ages and demand for senior services increases, Elderwerks will be there, offering more learning opportunities, activities, fun, and support that aging well and planning for future needs can be easy if you call Elderwerks 847-462-0885.
Hi, and welcome to Horizon Benefit Services, where we believe the key to health insurance happiness is both choosing the right insurance plan and knowing how to use it. That's where our care makes all the difference. We help you select the best plan at the best cost and provide outstanding customer service. Whether you're an employer looking to offer benefits to your employees or you need help planning your healthcare costs in retirement, you've come to the right place. We help you achieve health insurance happiness through our unique approach based on the 3 C's.
Comparing your coverage options to make an informed decision.
Confidently choosing the health insurance solution that best meets your needs.
Caring service. We offer virtual and in-person support to our clients because we care and want you to get the best value for your health insurance and healthcare dollar.
Horizon Benefit Services has decades of experience helping our clients navigate a complex and changing landscape. Our team will advise, broker, and advocate for you.
Come for the insurance and stay for the care.
Palliative Care, It's All About Living, is presented today by Lisa Wieland, nurse practitioner and advocate Aurora Health. Please welcome Lisa.
Hi, good morning. Thank you for being here today. My name is Lisa Wieland, and I am a nurse practitioner from Advocates Home-Based Palliative Care team. I was asked today to share with you all a little bit about what is palliative care and what do we do and how can patients benefit from it. So palliative care is a growing medical specialty. It has been shown to benefit those that are living with serious illness. Sometimes people get this confused with end-of-life care, and it is not the same thing. People can be involved in a palliative care program regardless of the stage of their illness. Palliative care focuses on symptom management and enhancing quality of life. For instance, someone who is undergoing chemotherapy and radiation as part of a cancer treatment program. Palliative care is often involved in the plan with these patients to help them tolerate the side effects that go along with treatments like chemotherapy and radiation. We are able to help them manage the side effects so that they can pursue their treatment as prescribed by their doctor. So this care is appropriate for patients regardless of age. It just is appropriate for people who are dealing with a significant medical condition. It is provided by an interdisciplinary team. So we work with patients' primary care physicians, their specialty physicians. We have a palliative care physician we work very close with. There are nurse practitioners and social workers on the team that I work with. We are a home-based program, so we go out to patients' homes. However, there are also outpatient clinics where patients are able to go and see a healthcare provider in the usual clinic setting. So if that's something I enjoy being able to go to people's homes because I really feel like it helps me to meet them where they're at and to really see how I can better help them. But there are home-based programs and there are clinic offices as well. So the biggest thing we do in palliative care, we focus on the assessment and management of concerning symptoms. We help patients to coordinate their care. We help families by supporting caregiver needs and making referrals for community resources when available. One of my favorite parts of my role as a palliative care practitioner is really helping people understand a disease process and understand their treatment options. Sometimes when they go into a doctor's office, they're given all kinds of information and it's very overwhelming. They go home and they think about it a little bit. They often come up with many questions, and that is where I like to step in. I like to help make sure that they understand what their diagnosis means, understand the trajectory of illness, like how it progresses in its natural course. Patient education is probably one of my favorite parts of my role as a palliative nurse practitioner. The reason that I enjoy this so much is because I really want to help patients understand what's going on so they can really engage in complex medical decision making, meaning that they can be informed about the decisions they're making regarding their treatment options, often with a significant illness. So, benefits of palliative care. There's a table here that lists them, but just to run through them a little bit. I really do think that the role of a palliative care provider is to help improve the communication between patients and their families and their healthcare providers. I often help patients with this aspect of their care helping to clarify things for them or helping to schedule follow-ups if they're not sure who they needed to see. We have psychological and spiritual care aspects available through palliative care. We have a social worker who is part of our team for each patient that we bring on to our palliative care program. And we also can make referrals to spiritual care providers like chaplains. We help be an extra layer of support for a patient and their families. And it really helps their quality of life, and it really helps increase their satisfaction with the care when they really feel that they can get, they're not calling an answering service and just getting bounced around from, automated operator to automated operator. When they can get a person on the phone to ask their question or voice their concern, it really helps keep them comfortable in that their questions are being answered. And it helps foster their independence in staying at home if they can seek guidance versus having to go into the hospital or having to go into the doctor's office each time they have a small question. So I really do value that. So like I mentioned, I work with a home-based palliative care program, okay? So I visit patients in their homes. I love seeing them in their own environment. It gives me more insight into their life and promotes a better understanding of what really matters to the patient. If I was seeing you in clinic, I may not know about your little dog at home that you consider your child and how important it is to you to be able to get up and take care of your little dog every morning. I use the pet as an example of goals of care, which I'm going to talk a little more about later. But someone recently, that was a goal of care when I asked them. I said, what is one of your goals here that we're working towards achieving? And she said, I need to be able to get up and take care of my little dog in the morning. It was a little Yorkie. And it was like a child to her, and it was a huge priority. Being a dog person, I understand. So it was very important to me to help her find the strength and the energy to be able to take care of her pet. So this is something I may not know in the clinic. I may not see that. I may not realize that the home is so small that there's not room to even like put a wheelchair in there. And I do follow patients who have very cramped living quarters, and that helps me to think of alternatives for them versus, if their energy is lagging or they're having difficulty walking, saying, well, we'll just get you a wheelchair. It only works if you can use it in the environment where you need it, right? So going into people's homes gives me so much insight, and I really do feel that it makes me much better able to help them than seeing patients in the clinic in that capacity. It also lets me see their functional status at home. Many patients would come into the clinic in a wheelchair because of a long walk from the parking lot or something, and I understand that. But it helps me see when you get up at home, are you able to get out of your chair, walk to the restroom, and come back without holding on to all the furniture, without tripping over throw rugs on the way? So it does help me get an assessment of functional status. It helps me see who else is involved there. Who are the caregivers? Is it family? Is it paid help? Is it homemaker support through the Department of Aging? It really does help me to understand who is there for the patient. And then I can tailor my plans for care around that as well, knowing that there's someone able to help the patient implement those plans. So it also gives me an opportunity to establish relationships that help facilitate these ongoing discussions surrounding care, right? It really helps with rapport building, and the relationships that I build with some of these patients really are very meaningful. All right, so a typical patient that we would see. So how a patient gets referred to us is their primary care clinician or a specialty physician that they see recommends it to them, and they place a referral. This is also something, if you are living with a complex illness, this is something that you can ask your physician for as a palliative care consult, okay? So our typical patient has advanced complex illness. It is associated generally with some type of functional impairment. It is not always a predictable trajectory or a predictable course, okay? So on the top box here on this slide, it says that many of these patients are not eligible for or interested in hospice services. So this is one myth I hear regularly about palliative care, that it is the same thing as hospice, and that is 100% not true. Okay? Hospice, I guess, is a form, it's probably the highest form of palliative care, but at least in our program, they are different. Hospice services are tailored on the end of life, when a patient is no longer able to or desires to seek curative treatments for an illness. At that point, comfort care services would be provided to a patient in their home. That's not the patient that I see. The patient that I see is very frequently a patient who is interested in still getting out and seeing their specialists, still going out and getting treatments. So my role there, an important part of what I see of my role there, is to support them in that, in being able to get out to their doctor's office, being able to tolerate their treatments by helping manage their symptoms. If it's not a patient that I'm seeing that is on a treatment plan, say it's someone living with long-term lung disease, being there to help make sure they have the right inhalers available, that they know how to use them, that there's certain breathing exercises and certain styles with breathing that can be done to help reduce shortness of breath. This is called a reduction in symptom burden, when we take what's bothering you and we try to reduce it, right? Whatever the symptoms, I can't always make them go away, but my ultimate goal is to reduce them to the point that you are able to do other things that you want to do, and ultimately enhance one's quality of life, okay? So when patients are involved in a home-based palliative care program, it reduces their likelihood of hospitalization because you have a resource. You have someone to call when there's something that just doesn't seem right. You have someone to come, if a patient calls me, I'll talk it through with them. Then if need be, I will go make a visit to them in their home and I'll check. Sometimes we can tweak a couple things in the home and they're able to stay in the home. Other times I find a concerning symptom and I say, yes, I definitely think you should get this checked out at the ER. Either way, it's a good resource for patients and families. So another important thing about palliative care is that patients enrolled in these programs are more likely to have what's called advanced directives and have engaged in goals of care conversations. So one of the most important advanced directives a person can have is a durable power of attorney for healthcare. And I have a little section on that later. We'll talk a little bit more about it, but we are able to help patients to fill these out and put these directives in place. And that is something I often do as part of my home-based visits, okay? So with a palliative care program, most patients continue to see their normal primary care doctor, their specialist. They go to the office, and then they get our home visits in addition to going out to provide an extra layer of support. Okay. Another myth I often encounter about palliative care is that someone has to be incredibly sick or at the very end stage of a chronic debilitating illness in order to be enrolled in a palliative care program. And that's not true. We highly recommend that people begin palliative care earlier in their journey with an illness. Like I said previously, this care can occur at the same time as all the other treatments, right? And we can help manage other symptoms that come up along the way with management. So we definitely want to be involved earlier rather than later. So when someone's diagnosed with a serious illness, it can disrupt their quality of life. It negatively affects the family. When you have specialized medical care involved, that's very patient-centered. We're able to address concerning symptoms of patients and help with stress. Stress is a huge component of what we deal with, what we work with patients and with their families. And we really try to help ease some of that burden via education, via referrals for community resources, via communication with their treatment team, things like that when we are able. I had mentioned previously that this comprehensive care is provided by a multidisciplinary team, and some of that is referred to again on this slide. So it is appropriate at any age and any stage of illness. Okay. So I'm going to go through who some of the members of the team are on the palliative medicine team that I work on. So once our office would receive a referral from one of your treating physicians, you'd get a call from our palliative care coordinator. So the coordinator would explain the program, answer any initial questions that you have. Then they schedule your first appointment with the nurse practitioner. Okay? They also will let you know if there's, they take care of some of the financial aspects of it to let you know if the visits are 100% covered by insurance or if there's any type of a copay involved. So once the palliative care coordinator sets up an appointment, that's where I come in. Advanced practice registered nurse, and that's my license, and I'm certified as a nurse practitioner. So I work closely with patients, their family, their caregivers, their doctors, and any other team members to really come up with a palliative care plan for symptom management, trying to assess and then treat problems, managing pain and symptoms like nausea, vomiting, things like that, providing education and support. And that is my role. We have, like I said, we work very closely with your primary care physician and with any medical specialists you work with it, oncology, cardiology, neurology, your doctors like that. So we always make sure that they are kept aware of what we're doing on our visits, what we're talking about, any questions a patient may have, any concerns we find regarding any medications, any interactions or anything, or if patients aren't tolerating a certain medication well. That's something that I often find where a doctor prescribed a certain medication during a visit, and then you are at home, a patient is taking the medication, and then they have a concerning side effect and they just stop taking the medicine. And the doctor has no idea often until a few months later when the patient goes back. So we're able to communicate this information. We find it out and can communicate it a little more quickly, and we can make changes so that no treatment care plans are interrupted or then they don't go off the rails. So the last role on this slide is our palliative care medical director. This is a physician who is an expert in symptom management. This is our resource. Anytime I come across something that I would like to talk about with the doctor for symptom management, or for instance, I have a patient who I've done all the normal things and it's still just not quite working, and I'd like to talk it through with someone, that's when I reach out to our medical director. And ours is a woman named Dr. Battle, and I talk these things through with her. Someone else I work very closely with on our team is our social worker. So she helps people work on identifying and addressing the effects of serious illness, what role it plays on psychological and their psychosocial needs, the families and the caregivers. We talked about that stress before, and that's what everyone will tell you, how stressed they feel with dealing with a major complex illness. So we have social workers who help with this. We have one on our team that does counseling therapy sessions. We have another on our team who helps with identification and referrals of community resources. Like that is like referrals through the Department of Aging for homemaker services, or referrals to Meals on Wheels to help people get resources that they can use. And then we also have, if it's requested, we actually have access to a chaplain for spiritual support. So some of our goals are on here, that we want to help you understand your medical condition, your choices for medical care, help patients navigate the very complex healthcare system. We want to listen to your concerns, Having a home-based palliative care provider means that we can take extra time to listen to you and explain things and answer questions for you and your family. It's often something just that your treatment team and a lot of your physicians just don't have time and ability to do in a 15-minute office visit. You know, sometimes even if you get that full 15 minutes. So I also feel that one of my responsibilities is to help empower patients. I take that very seriously. My goal by really trying to help you understand your options and understand the course of an illness is that it helps give you more control over what is happening to you. Sometimes I'll write down questions for you that we'll talk through, but then things that I want you to talk about with your doctor so that it helps give you control. I can help you come up, you know, a lot of times you hear, take a list of questions to your doctor visit. And sometimes you're like, yeah, but I don't even know what to ask. I've heard that many times. I help you come up with the questions to ask of what kind of information, you know, you really would like to know and to get from your doctor too. So, and then of course, we work with just providing care for complex symptoms and then chronic disease management. I think that is all referred to on here. The last thing on this slide here is it talks about is preparing advance directives. A lot of people think that you have to go to an attorney to get power of attorney for healthcare paperwork done. That is not true. I don't know about everywhere, but in the state of Illinois, we are able to help people fill out the advance directive of a power of attorney for healthcare. And then our social worker, the one who works with identifying community resources, she is able to sign it also as a witness. Healthcare providers aren't supposed to sign as the witness in the state of Illinois, but our social worker who does not treat patients, she is able to sign as a witness so that we have these conversations about what the responsibilities are of a power of attorney for healthcare. And then once we talk it through, you name who you would like your agent to be. And what that means is your agent is who speaks on your behalf if for some reason you're unable to communicate or make your own decisions. For instance, being involved in a serious accident where you're left unconscious and decisions need to be made, consents need to be signed, decisions regarding blood transfusion, surgeries, things like that, different medications. And then this offers you the opportunity, when you prepare an advance directive, it offers you the opportunity to say who you want to speak for you when you are unable to speak for yourself. So it's very important. So as this is a good lead-in to my advanced care planning and my advance directive conversation. So as I've already mentioned a couple of times, this power of attorney is very important. We really all should have one, regardless of age. You know, sometimes people think, I've had people that I followed in my, people that are in their 40s or 50s say, well, I'm pretty young, or I don't need one. Yeah, I'll do it when I'm older. Or a lot of times people think, well, I'm married. If something ever needs to be said, my spouse, my husband or my wife they'll make those decisions. So the law does say that. The law does say if you are married and you don't have a power of attorney, your legal surrogate decision maker would be your spouse. However, what if something happened where you and your spouse were involved in a serious accident at the same time? And it happens. So this is why we highly recommend that people complete this paperwork. And you absolutely can designate your spouse as your agent, but on the power of attorney paperwork, it allows you to put backups to the alternates, right? So you have if you want your spouse to be, your spouse can be your first line agent, but if your spouse is unable to do it, who's next? Who would next speak for you? And ultimately and ideally, these are people that you have shared your wishes with. For instance, your wishes about ever having feeding tubes put in, ever being on dialysis, ever having a blood transfusion. So these are just, the tip of the iceberg of issues that come up. So it is so important to have these conversations. So, and that is what advanced care planning is, right? We are planning for care in advance of needing this. Okay. One other advanced directive, and this comes into play more at the time when people have been diagnosed with a very serious illness, often what could be considered a terminal illness. And this is something that we encourage people to talk about. You'll see this 5 wishes booklet here. So this is the cover of a booklet that talks about, it's for patients, and it encourages them and gives them some pointers on how to talk to their family about end-of-life care. You know, it does talk in there about making a power of attorney to designate one, but it talks in there too about, you know, if your heart were to stop, do you want CPR? Do you want resuscitative efforts? Do you want to be put on a ventilator, breathing machine, things like that? The form all the way over at the end is called the Physician's Orders for Life-Sustaining Treatment. That's a post form. So this is through the Illinois Department of Public Health. And on this post form, you can designate whether you would ever want cardiopulmonary resuscitation, like CPR and shocks. It says on here, would you ever want artificially administered nutrition, which is like tube feedings? And you can put things on here. For instance, it's very common in section B there under medical interventions. People say, I want to have, the middle one is very common to choose, to say, I want limited treatment. I want oxygen. I want antibiotics. You know, I don't want to, you know, I want to be treated. You know, I want pain controlled. But at the bottom, that line there, it's very common, or not very common, I shouldn't say, among certain, say, religious populations, to say like no blood transfusions. Among one group of people that I work with, they may say no blood transfusions. So that's something that we, you know, in sometimes the population that I work with will put on there. You absolutely, this is your spot to designate that. Again, planning for what type of care you would want or that you know you absolutely would not want in advance of needing it. It absolutely takes stress off your loved ones in that time of crisis. Okay, excuse me for 1 second here. All right, now we're going to talk about goals of care. So when you are dealing with a very serious illness and a potentially life-threatening illness, our palliative medicine team helps a patient and their family identify their goals of medical care. I mentioned earlier the little lady who said, you know, she was under treatment for cancer. And I think it's very well known that treatment for cancer can promote a lot of fatigue and for patients not to feel very well. So her goal was, you know, she said about wanting to be able to take care of her dog. And that was so important to her because she did not want to give up her pet. That was her companion. But really the main thing is that kind of that reason to get out of bed in the morning. You know, she needed that reason to get out of bed in the morning, and what got her up out of bed versus just laying in bed and getting depressed about her medical condition was that she was getting up to take care of her pet. So as an illness changes, the goals may change, right? So what this means is someone may start cancer treatment with the goal being, I'm going to do whatever it takes. We're going to see what happens. We're doing very strong medical treatment. Well, something happens maybe that a patient doesn't tolerate that as well. So it may be like, okay, the goal might change. We're not going to do chemotherapy anymore, but we're going to try the oncologist recommended immunotherapy. Okay. And then my goal may be, you know, to try to treat this, to try to fight this as well as I can. And my goal is to prolong survival, right? When we're on those treatments, we want to live as long as we can, right? So sometimes we get to a point where in an illness with a patient where the doctor says, all of these treatments are not working. Your cancer is still growing and advancing despite us trying multiple different medications. And then sometimes people say, let's try some of these other medicines again. Let's look for clinical trials or experimental medications. And some people say, I'm tired of these side effects and I just want to be around my family and be comfortable. And then we talk about pain management and comfort care. Right? So these are very personal decisions and they're up to a patient you know, in conjunction and in conversation with their families to make these decisions. And we are here, the palliative medicine team, we are here to provide guidance and support and answer questions in helping patients make their own decisions. You know, I want to reiterate how important ensuring patient autonomy is to me, and that patients are the captain of the ship. And I feel like when someone's dealing with a medical illness, very often some of that gets shifted over to the doctor that's heading the treatment team, or someone else providing the care, where it's always very important to remember that the patient is the captain of that ship. And it is so important that they feel like they are in control. Okay. So we talked about how we have these goals of care conversations. Let's talk about 3 common goals of medical care. And this is what I help with people and help people to really understand where they're at on this spectrum. So cure, the focus is to cure an illness. It is the gold standard in medical care, right? For example, we get sick, we say we have a sinus infection, we go, we get antibiotics, we get our treatment, we're better, right? That is a cure. Our sinus infection is cured. Some early stage cancers can be cured. Now, stabilization to prolong life. That occurs when we have a serious illness that cannot be cured, but we want to stabilize it. And we really can stabilize certain conditions to promote people living a long and full life. So this would occur with, say, COPD, like emphysema. There is no cure for that. But there is management for it, right? We have people use certain inhalers. We talk about breathing exercises. We talk about, I often talk about people to pre-medicate with an albuterol inhaler before they go out to do things that they know cause shortness of breath for them. So we work on symptom management to they're stabilized to prolong life, and we work on how to promote that quality of life, okay? So all of the medical treatments with this goal, they're directed at stabilizing an illness, stopping the disease from progressing, maintaining symptom control, and of course, we always want people to be comfortable while managing an illness. The last one on this list is comfort care. When we talked about if a patient does not have hope for any recovery or true stabilization any longer, the focus of care is shifted to provide comfort. And this is during a time when people often would transition to hospice care. So what's the difference? We talked a little bit about it before, but just to go over some of the finer points. A patient can enroll in palliative care at any stage of a serious illness or an uncontrolled medical condition. We are available to offer supportive care with or without curative intent, right? In hospice care, a patient must have a medical condition that is considered terminal. Generally, their prognosis is 6 months or less. There is some variability there, but that is a standard. The focus of hospice care is comfort care. There's no curative intent. Now, that doesn't mean, this is a myth I see sometimes. If someone, say, for instance, were to get a bladder infection while they're under hospice, you absolutely can take antibiotics for that and be treated for that. Okay, it's things like that that come up while you're on that. But the major illness, you know, you're not having surgeries to have a lung transplant. You are not going, generally, you're not going to hemodialysis for kidney troubles anymore. The pure focus of this is comfort. And you see right in the middle there, there's a little spot where they intersect. We both programs, we both focus on relief of symptoms, and can be, both programs can be implemented and delivered in different environments. As I mentioned, I work in. All right, and so this is just a nice little table. I'm all about these little tables that kind of sum it up and give you the quick the quick information. And I put this in here so you could have it as a reference if this was something that ever was something that you needed to know. Okay. One of the questions I do get too is about insurance. Coverage varies for palliative care and hospice care. Most cases for palliative care, a copay would apply just like a regular office visit. And then for hospice, there's no charge to the patient for the hospice care when it comes through Medicare, Medicaid, and most private insurers. It is a benefit in that. So generally at that point, there is not a copay for the different visits. Okay. All right, so this is just a little a picture that I found that I really liked, that I kind of sums up what palliative care means to me. A couple of words to highlight on here is person-centered, and I called that patient-centered before, but autonomy at the top. They're individualizing care, making it patient-centered to help fosters a patient autonomy so that they can make their own choices, right? Which I find very, very important. I really consider part of my role is to empower them, to educate and to empower patients as a palliative care nurse practitioner. All right, well, it has been wonderful speaking with you today about this. I am eager to take any questions that you may have. So please, thank you for listening to me and listening to me talk about something that I obviously feel very passionately about. And I'm happy to answer any questions that anyone may have.
Hi, Lisa. I'm Jenifer. Hi. We don't get to see you live. We usually just email.
Well, it's nice to see you.
Nice to see you. I'm glad I get to see people again. I liked your presentation. I thought it was very thorough.
Well, thank you.
You're welcome. Palliative care is usually one and done. It's like 5 seconds of explanation, but you did a very good job getting in depth in that.
Thank you. I know they had asked me originally, someone had said something like 45 minutes, and I was like, I think I had like 37 on there. I'm like, that's as long as I can get without being too redundant.
Well, the watchers might get bored after a while. So, it's important to get across what the important aspects are of palliative care, which I think you did. I know that many people think that hospice and palliative care are one thing.
Yes.
Versus you can get palliative care just because you're in chronic pain. Absolutely. So I'm glad you defined that. Currently, we have a lot of issues in the last year and a half. I know you know. It's just been so fun. I don't know what your experience has been for yourself with the COVID crisis, but do you find that COVID is making people plan better for these emergencies? Or do you think it's still, when they get to you, it's a mess and you need to direct them more?
I actually still feel like it's a little bit of a mess. People, I think, maybe have a little more of a heightened sense of awareness, maybe of, for instance, as you noticed in the presentation, really the most important thing to me is that we really talk about the durable power of attorney for healthcare. So people seem to understand the risk of it. I think seeing on the news about patients being intubated and ventilated because of COVID, I think people have understood, they can put a picture on what that means to be able to be in a scenario where you can't make your own decisions and speak for yourself. So I do think it's helped to heighten the awareness, but I do find that people are maybe more willing to complete the paperwork now, but we are still doing a lot of it. People haven't gone out and gotten it done in the midst of the crisis.
That makes no sense. Makes no sense whatsoever. I had a friend get COVID. This poor guy has been through, like the last 10 years, he had a back problem. He had back surgery. It took him a year or 2 years to recover from that. So he was finally walking again. Yeah. And he went to the dentist. I know I shouldn't say this out loud, but he went to the dentist. Not my dentist. My dentist is like OCD. They're like aliens. They're so protected. He got COVID at the dentist.
Oh my gosh.
Yeah. And he does have his docs in order and everything, but it attacked his back where his surgery was. So the pain was extraordinary. They were doing palliative care on him. That's why I wanted to mention that, because the palliative care they gave him helped him recover. He's not fully recovered, but he can smell and taste again.
Good. Okay, good. They worked on helping him maximize his function and maximize his quality of life.
Right. He's getting there. He's now chipper and he's out and about, but
I'm glad he's doing better.
It's not fun. And, you know, with the COVID, are you finding that people are having pain management needs after COVID?
I've actually seen people present with quite a bit of neuropathic pain. So we're actually working with patients with that. I haven't worked with patients who have gone to, like, for instance, where he had that weak spot in his back and it sort of attacked that. I've seen patients who, because of neurological complications of COVID, who have developed peripheral neuropathies afterward. And we work with some of that. I see a lot of fatigue and I see a fair amount of peripheral neuropathy.
So I'm 99% positive I got COVID in 2019 after a cruise.
Oh.
I just want to say that was the worst experience of my entire life. It is not pleasant. I hope that everybody gets vaccinated. I'm totally into let's protect ourselves.
Yes.
It was 6 days, 103 fever.
Wow.
Yeah. The flu-like symptoms. I couldn't even move my finger without being exhausted. I'd move my finger, got to take a nap.
Yeah. Oh my gosh.
And then I didn't finally feel better till the mid-March.
Okay. Oh my goodness. So,
and for me, I'm a total spaz. I do not sit around. I don't like being on the couch. I don't like being down for the count. Usually I'm sick. I work at home, of course, because I'm not getting anyone else sick. But I appreciate what you do. Pain management is huge because if I had any more of that pain, I probably would be seeing you saying, help me. Right.
Oh my gosh, you know, and it is, you know, in the population that I work with also, so it's, you know, a fair amount of the patients are quite elderly who, they've been hit harder by it. And I have seen some of the sequela of that. So it's so what I'm seeing them for a lot of the issues, it's not because they had COVID, but they had it. They recovered acutely from the COVID, but they've developed so much debility, reduced functional capacity in the time following it that is just directly related to how hard they were hit by the virus initially. So yes, I absolutely agree. Get vaccinated.
Yeah, it weakens the system. We don't need to be any weaker than we are, right?
Right.
Oh gosh, I just wish that people would listen, you know.
Well, I hear you.
Are there any prevalent issues that you're seeing that you're helping with this programming with palliative care? Are you seeing anything in particular, like more like let's say injuries versus arthritis or something like that with pain?
So with the pain management aspect, not as much. So primarily when we work with patients with pain, a lot, probably 3/4 of the patients that I work with pain issues is related to cancer. So not so much. I mean, of course, many have arthritis issues coupled on that. And we don't work with patients really with too many acute issues like, I threw out my back or I just had back surgery. Our program doesn't do too much with that. We definitely do with more longstanding or chronic or then like cancer pain.
Right. My mother-in-law had, what did she have? She had a bone cancer.
Oh,
yeah. And she was in pain. Every single part of her body was in pain. And she went through the palliative care program and it helped her because she couldn't move. Right. Yeah. So the palliative care program is a necessity. And if you have that pain, there's no reason to live in pain.
Right. And like I said, like in the presentation, so pain is a large part of what we work with, but also one of the things that we do and one of the things that has really been encouraged lately is for instance, oncology patients is to get palliative care involved a little earlier to help them tolerate their treatment. And the side effects of chemotherapy, radiation therapy, they can be daunting. And I mean, it happens all the time where people just can't tolerate those side effects. I had a patient very recently. The treatment was working. He was on chemo radiation. It was working very well. His scans were improving, but he became so sick and so debilitated, they had to stop. So
that's no good.
Yes. So I think one of the goals is getting in earlier to help control fatigue, control nausea or vomiting, to be able to get people able to tolerate that treatment. That's a big goal. That's important to me, is helping patients tolerate their plan to help with their goals of getting past the treatment and getting a hold on their illness.
So when they visit the oncologist, does the oncologist say, hey, go see this palliative expert right now before anything starts so that they can prepare them for?
So it didn't used to be like that. It used to be they'd put us on when they were already super debilitated. They'd put us on like when they started having a hard time tolerating the treatments. But we're actually seeing a shift in that. We're seeing that we are getting consulted earlier.
Good.
And I like that. I really do like that because, and here's the thing too, it gives you the opportunity to really develop a rapport with a patient and their family, to get to know them a little bit, and for them to get to know you and to develop some trust in what you tell them. Because then if we do get to a cross in the roads where they need to make a decision and things are very, things become difficult, they feel like they can trust you, they can rely on you to ask you questions. Whereas sometimes just meeting them at that moment, it's harder for them. They don't know you, you don't know them, you don't know what's important to them.
Right.
I like being involved earlier in the process.
Ooh, it's all right. My lights go out in my office if I don't move.
Oh no.
I looked like I was flying in a balloon there for a minute. God, nothing like a little embarrassment. I've been sitting at this desk way too long. Oh gosh. Now I lost my train of thought. Don't you hate that?
Oh, I do. Happens all the time though. I get it.
Oh, good, because I feel like I'm the only one sometimes. I'm like, what was that word? I have a lot of people filling in the blanks for me a lot of the time.
My favorite is, wait, why did I come into this room? What did I come in here for?
Where's my phone? Oh, I put it in the fridge. Good. That's lovely. So I think what you're saying is if you are going to go through any type of cancer treatment and or your loved one is, maybe be an advocate for yourself or your loved one and say, hey, can I talk to someone about this before this process starts?
Yes,
that might be a good idea. And that would be covered by insurance.
Yes. And actually a large percentage of the people that I follow have no copays for us to come out to their home. Some commercial insurance plans do. But many, like a lot of the Medicare Advantage plans and such, have no copay. It costs nothing to see us.
Well, that's
so really there's no reason not to.
I think people don't because they don't, number one, don't know about it. Or number two, they're just scared and they can't move forward yet. And sometimes that's, you got to start at some point, and maybe the point is starting with the process and then getting the pain and then seeing you. That might have to be their process, but it doesn't have to be their process.
Right. And we actually are getting, I've had more and more referrals lately. I would say, so I've been in this department for a little over 3 years. And I would say in the last 6 months or so, I have seen a shift to sometimes where you'll see in their treating physician's notes, you'll see them notated. Patient's daughter asked for a palliative care consult.
Woohoo!
Right. We're getting the word out there.
Thank God. Do you put literature out on palliative care and why it's important to get you in there in the beginning of the process at all?
And so I don't personally do that other than kind of talking to community groups and doing things like this. But there are people that do. Our spiritual care department, I know that some of the chaplains are very involved in that as part of their community outreach and encouraging planning. Yes, so there are people that do that.
Okay.
Well, if you ever spread the word.
If you ever do an article or have a piece of literature, we'd love to share it on our website and to people who walk in our center here in Palatine, because it is hugely important.
Yes, definitely. I will. And listen, I will definitely keep that in mind.
Thank you. Is there anything you want to say before we close?
No, I just, thank you to everyone who attended the talk today. And I hope you learned something about palliative care. And really, if there's something that you heard in there and you feel that you could benefit, advocate for yourself and ask your clinician for a referral. You really have nothing to lose.
No, maybe a little pain.
Right. Yes.
That would be good. Anyway, thank you so much, Lisa, for coming out today. And I'm sure we'll send you some more families to help.
Well, wonderful. Thank you so much. Thank you for giving me this opportunity today.
Of course. You take care.
Take care. Bye-bye.
Bye.
Elderwerks Educational Services is a not-for-profit 501c3 organization providing senior living coordination, advocacy, and education to. In many instances, our consultants serve as a lifeline or personal confidant to older adults who literally have no one living nearby. Elderwerks prefers senior housing options and providers based on you and your needs. What did you used to do? What do you do now? And what do you want to continue doing? We provide complimentary referral services to vetted supportive care providers and help families and acquaintances secure personalized living and benefit information. Our consultants are experts in senior housing of all types. We have toured the senior communities in Illinois, documenting the services, amenities, and quality of care to ensure seniors transition to the best options based on their individual. People view aging much differently than those of previous generations. Our seniors want to be connected, relevant, and celebrate life in active, vibrant surroundings. We've helped thousands of clients secure and maintain a quality of life that suits their personalities. As the population ages and demand for senior services increases, Elderwerks will be there, offering more learning opportunities, activities, fun, and support that aging well and planning for future needs can be easy if you call Elderwerks 847-462-0885.
Hi, my name is Mike Iwaniki from the Veterans Assistance Commission of McHenry County. We are located at the McHenry County Government Center in Woodstock, Illinois. Since 1989, the Veterans Assistance Commission has been helping veterans with the presentation and prosecution of their claims, with transportation to and from the Lovell Federal Health Care Center, and with financial assistance needed for some of our low-income vets. Enough about us. It's time to get fit. Please help me welcome Jenifer Anderson from Advocate Good Shepherd Health and Fitness Center. Jen has been in the fitness industry for 18 years, and she loves to find fun ways to move and stay fit. As the group exercise director at Good Shepherd Fitness Center, she oversees 100 classes per month. She believes that fitness should be fun, and she truly enjoys celebrating the success of members as they keep moving. The body and mind truly benefit from movement. So please join in and do as much as you can. This will be fun. I'll turn it over to Jen right now.
Hi guys, my name is Jen. I am from Good Shepherd Fitness Center, and we are about to do a chair aerobics workout together. So we'll do a little bit of strengthening, some core work, and we'll definitely move and get our heart rate up. So all you need is a chair, and I have a towel that I'm going to use as an accessory. If you don't have one, don't worry about it. You can do everything without, but sometimes it'll just give us a little bit of structure for some of the strength exercises that we're going to do. So I want you to go ahead and sit yourself in your chair nice and tall, and remember to keep your spine stacked, abs tight. Take a deep breath up and lift. Exhale out. Do it again, lift and breathe. Exhale it out. March your feet, here we go. March, march, good. Nice and tall. Good, good. Now, we're warming up. Tap your heels forward, push. Good, little push. Beautiful, this is gonna be some brain work too, guys, which is all good. We need it all, right? All right, guys. Feet to the side, arms to the side. Oh, what is your body doing? Staying upright, yes? Good. That's what I was hoping you would say. Keep working. Ready? March your feet. March. And we're pumping our arms with that march. Sitting tall, shoulders down. Push your heels and hands. Front, front, front. Starting to get a little bit of heavy breathing. That's good stuff, guys. We like it. Body's getting warm. Ready? Feet, side arms. Lift, lift, lift. Shoulders down. Sit up nice and tall. Push. You got it. All right, guys. March your feet. March. Take your arms down. Roll your shoulders back. We're still warming up. Roll your shoulders back. Do it again. Roll in front. Roll in front. Good. Let's take both arms in front. Clasp your hands. Stop your feet. We're going to warm up the core. I want you to twist it right and center and left and center. Warming up that core. Right, center, left. Beautiful. Couple more. And left, center, drop your hands, reach down right, center, good. Warming it up, nice and slow and controlled. Every single time, we come right back to the center here, in a nice upright position. Couple more, go. 4, and up. Good, 3, and up. 2, last one, here we go, reach it, and bring those arms up, lift, march the feet, one more time, big lift, good, bring it down, shoulders back, body upright. We're going to start with the lower body, plant your feet, plant your seat, work this muscle too. We're going to lift our right knee to the sky, ready, lift and lower, good, lift and lower. Good, good. Keep going. Squeeze it. Squeeze. Couple more. This is working. That big muscle in the front and your muscle in front of your hip. Yes? Switch sides. Here we go. Up, up. Good. Lift and lower. Beautiful. Good work, hard work. Got it, guys. And you got 4 more. I'm counting in my head for all of us. Ready? Take this right knee up and then out to the side, in and down. Left side, lift up, take it out, in, down. Working on a little of that hip mobility. Only go to your own range of motion, okay? When you lift, if all you go is right here, that's you. That's good stuff. Lift it, open, in, 2 more. Up, out, in, 1 more. Now, only the right knee lift to the sky. Here we go. Lift, down. I say this is like a string tied to your knee. What is your body doing? Don't collapse in. Sit up tall. Engage that core, guys. Lift and down. 4 more, then we switch. 4, 3, 2, and other side. Here we go. Take it up and down. Up and down. Good. Lift. Down. Sit up nice and tall, my friends. Lift and down. Squeeze. Feel that muscle work? Feel the front of that hip, guys. 4 more. Here's 4 and down. 3. Good, good. 2. And bring that right knee up and open. In and down. Switch. Up. Out. In. Down. Beautiful. Up. Good stuff, guys. Staying up nice and tall. Remember, when we get tired, we start to hunch down. We want to keep our chest nice and high, keep our abs engaged. 2 more, this is it. Out, in, and down, and up, out, in. Good, march your feet. Now, if you have a towel, you can grab it. If you do not, you're going to bring your arms out. So I'm going to grab my towel with both hands right here. And I'm going to pull my shoulders back. Let me show you from the side. So it's going to look like this. That's it. All you're doing. If you don't have this towel, you're just moving your arms back. You can even clasp your hands together if that helps. Okay? Do a few of these for me. Here we go. Pull and out. Pull. It's a different kind of a movement, but it's going to strengthen right behind that back where we want to round in. We want that nice and strong. Pull it in, out. Good, good. 4 more. 4, and out. 3, squeeze it, keep your shoulders down. 2, and last one. Bring your hands down, towel or no towel. Sweep it up, here we go. Sweep it up, bring it down. Good, and sweep, and down. If you don't have a towel, what are you doing? You're sweeping, and bringing it down. Good, sweep it, and a couple more. Nice mobility through those shoulders, guys. And if they come to here, they come to here today. It's a little different every day, yes? And we're gonna bring them out front, pull back, in, and in, yeah? Back and in. Nothing else moving, see that? Squeeze. I'm pinching my shoulder blades. Oh, I'm feeling the work, guys. You will too. You got 4. You got 3. Here's 2. Last 1. Bring it down. Sweep it up and down. Why don't you march your feet with this? Sweep it and down. Couple more. Big sweep and down. Lift down. Now, if you have the towel, you can keep it. Okay. Bring it into your left hand. You're gonna tap it out. Reach. Did your video freeze or did my body freeze? Well, it was my body, because my brain had to catch up to my body. If you don't have a towel, guys, what is happening? You're doing the same thing, right? Arms coming up and over, go. Come on, come on. Woo! Ah, now my towel's flying all over. Good, good. going to reach it out and push. Here we go. Push, bring it in. Push, bring it in. You can stay at this pace, or you can make it a little faster. Huh. And if your towel gets messy, well then that's just part of life, isn't it? Keep going, reach, reach. Huh. I like this little accessory. It's this tiny bit of weight. My hands are gripping. Yes? Grip strength is important. 4, 3, 2. All right, push it out front. Push, push. Good, shoulders down. Body is upright. I am sweating, guys. Push, push. You got it. All right, guys, here we go. Out, out, out. There we go. See, I told you I'd catch up. There we go, there we go. Fitness is always a little messy, like now. And that is okay, right? We don't need perfection. We don't need to look like the workout videos. We need to look like us, doing our jobs, working out, moving our bodies, and smiling, yes? Ready? Bring it front, march. We're gonna push it, side to side in 4, 3, 2, 1, here we go. Push, push, huh. You're switching to, reach it. Beautiful. Get some good deep breaths in, let's go. You got it, guys. Hey, I'm sweating. Woo! Good stuff, good times. This is, hands down, the best part of my day. Mark it out in the front. If you have your accessory, you can send it to the side. You can put it away, okay? Now, arms up, arms up, arms up. Yes. This is also a little shoulder. If we had little hand weights, this would be a little shoulder for us. Yes or yes? Oh, good. I thought you would say yes. We're going to make these into jumping jacks. Here we go. So you can do one leg at a time or both. We're sitting in the chair. You decide. Shoulders down. Good. A little interval for us. Lift and lower. With those arms. Let's go. Come on, come on. Halfway. Come on. Ready? Couple more. Give me 4. Give me 3, 2, 1. March it. Shake those arms out. Plant your feet in front. Lift your heels. Lift and down. Lift and down. Let's sweep the arms. Lift, down, lift. Little strengthening for the calf, for the ankles. Squeeze, down. Come on. Take it up. Good. Reach tall. Couple more. Reach. You got it, my friends. Lift. Now, take those feet, march them. March them a little bit forward. You're gonna plant your heels and you're gonna lift your toes and you're gonna curl your arms. Now we're walking and chewing gum again. We're doing 2 things at the same time, yes? Lift and down. Good, squeeze. Down, squeeze, huh. Again, if we had little hand weights here, what? We'd be working those biceps. They like that. What else are we doing on the bottom? We're working the front of the calves, yes? We need that nice and strong, right? So that we can pick up that foot. When we're walking, when we're driving, lift and down. I'm counting. Lift and down. Yes, yes, yes. Up. Abs are still tight. You're still tall. Lift up, down. 7 more. Squeeze it. 6 and 4 more. 4. Here's 3. You got it, my friends. 2 and march your feet. March your feet. March your arms. Nice and tall. Remember, we're not collapsing in. You're not working at your computer, looking at a phone, right? Sit up nice and tall. Open that chest. Abs tight. Push your heels. Let's go. Front and front. We're going to finish strong. We got a couple more seconds here. Then we're going to stretch, which we love. Yes, yes. Now, back to those jumping jacks. Take them up. Good. Beautiful. Good, good. Keep working. You got it, guys. Go, go, go. Push the heels front. Push, push. Come on, like you're closing the door. Push. Work that. Most important muscle. Right here. Come on, come on. All right, guys. Checks up. Here we go. Here we go. Up. You got it. Home stretch. Woo. 7, 6, 5. You got 4, 3, 2, 1. March your feet. Take a deep breath in. Feel good about this. Good. Roll your shoulders back. You can stop your feet. Roll your shoulders back. Feel good about this. Yes? Roll your shoulders front. This is the best part of my day. Hands down. I said it before, I'll say it again. Lift and breathe. Exhale it out. Getting to be here with you is a big deal to me. Take your right foot, toe up, hinge forward at the hips. You're just giving me a little lean forward with a nice straight back, yeah? Just like that. Good. You'll feel that stretch behind your low back and in that hamstring. Now, point that toe. Keep that lean just a little bit. When you point the toe, hold that hamstring a little bit longer, yes? 3, 2, 1, bring it up, switch, heel up, hinge, hold, point your toe and hold. Beautiful. Feels good, guys. Bring it up. Take your right foot, right ankle over your left knee, and if this doesn't feel good, bring it, keep it down here and give me a little tree pose. This would be like a yoga pose. You're just turning that knee out a little bit so you stretch that hip. And if you can get up here, go ahead. Your choice. Still sitting nice and tall. There are choices for every single exercise on the planet, so we can go to the other side. Tree pose here, or bring it up. You decide. Your workout. Yes. Nice and tall, guys. Feels good. Plant your feet. We're gonna do a little cat and cow. So hands on the thighs. We're gonna push ourselves back. Now you're gonna round back like I told you not to do. You can do it now. And then you're gonna push forward. And then you're gonna do it again. You're gonna round, and you're gonna push. And you're gonna round, and you're gonna push. And it feels pretty good. One more time. Round it, and push. Roll the shoulders back one more time. Good, take that right arm across. Heart rate's up, I'm sweaty. I hope I brought a change of clothes. Bring it down, switch. Good stuff, my friends. Bring it down, last time. I'm gonna have you take a deep breath in, lift and breathe. Fill your lungs. Exhale it out. Sit up nice and tall. Drop your chin to your chest. Woo. Breathe here. Bring it to the middle, right ear to right shoulder. Middle, left ear to left shoulder. Middle. Last time, big deep breath in. Bring your 2 palms together. Bring them down in front of heart center. Great work. High five. Thank you for being here with me today. Awesome job. It's about the movement, guys. It's about keeping on, right? We're gonna keep moving. Awesome work. I will see you next time. Have a great day. Hello. Hi, guys. Okay, so our next piece of the puzzle is a 10-minute core and stretch workout. So I have all of our exercises right here. You don't get to see them all, not all at once, but we will do 10 exercises go through them. Everything's gonna be about the core. Everything's gonna be about the back. We've got a little bit of a warm up to start. And we're seated the whole time, best part. We can stay seated. So, sit up nice and tall. I want you to start by stacking your spine. Lift and breathe, lift. Raise those arms to the sky, bring them down. Do it again, lift and breathe, take it up. And exhale it down, beautiful. March your feet and pump your arms just a little bit. Again, we are just getting warmed up to get this core working, yes? Tap it out, side to side. Good, side to side. And I'm gonna push my arms forward so that my chest and back gets a little woke up too. Couple more. Take it back to the march, here we go. March it, good. Nice and tall. Remember, when we're doing anything seated in our chair, we're stacking our spine, yes? Breathe. Reach it up, keep the feet moving. Bring it down. Do it again, reach it up. Bring it down. All right, guys, you're gonna stop your feet, reach across. Reach and middle, and reach and middle. Good, a little bit of a lean is okay. Yes, reach it. My feet are nice and wide. I have extra support there. Yeah, reaching it up. Take it up. Up, good. Reach and move in that rib cage away from the hip. Good, good. All right, my friends. Reach across again. Twist, middle, twist, middle. Good, twist, twist. Couple more. Give me two. Last one. Bring it up. Reach. It's my favorite move. Bring it down. Feels like you're just letting everybody know that you just did some hard work. But we haven't even started yet. So, sit up nice and tall. I'm going to lose my glasses here before I lose my glasses. Okay? So, sit up nice and tall. I like to have a chair with no arms. If you have a chair with arms, then it's okay. I am also a little forward on my chair, which is okay. And again, my spine is stacked. So when I'm doing these, I want to sit up nice and tall, opening my chest. So I don't want to be rounded through here. Everything is up. We're going to start with a little reach down to the side, right and left. Here we go. Take it right, middle up, left side. And middle, good. You are just dropping that shoulder a little closer to the hip. Yeah? Starting to wake up that oblique. Reach down, pull it up, stack in the middle. Reach down, stack it in the middle. And up. Good stuff. Should be getting us going a little bit here. Feeling when you close the distance, rib to hip. Yes? Down. Middle, you got it. Good. Let's do 4 more. Shoulders down. 4. And up. 3. Feet are about hip width apart. Nice and firm on the floor. Lift and now. I want you to bring your hands up here as if you were a little bit of a boxer. Twist it right, center, left. Right, center, left, center. Now, again, my hips are staying forward and my arms are coming up so my shoulders can get a little involved. Yes, twist it. Or, well, if I were a boxer, I'd always have my hands up. Twist it right and center and left and center. Good. 4 more, please. 4, 3, 2. Now, hands stay up, dip your shoulder down, dip and middle, dip and middle. We're going a little faster than our first side dip, yes? Good, side, middle, side, middle. Again, stacking your spine every time. Body should be upright, smile should be on, light it up. 4 more, 4, 3, 2, last 1. I'm going to take my arms up here behind the head. I'm going to open my 3, 2, 1. Crunch and lift. Keeping your elbows nice and wide. Keeping your chin off your chest, right? As if there was something, tennis ball right here, yeah? Down and up, and I'm keeping my elbows nice and wide. Beautiful. It's a nice crunch, and we're supported by that chair. Good, give me a couple more. Beautiful. Just bending forward, and then sitting up and fully stacking. 4 more, lift. 3 more. 2. 1. Now, elbow across to the knee. You can lift. Now, notice my body is not coming all the way down. I want you upright. You give me a twist and you give me a lift. Come on, I like it all. Yep. Good. Breathe. Elbows wide. 8 more. Yes, I'm counting. I promise you. We're working through, guys. 4, 3, 2. Now we're gonna make it a little longer. I want you to reach across and lift your toe. Ha, lift. I'm gonna keep my arms up, lift. Guess what else is working? Behind those shoulders, reach. Ha, don't worry if you can't touch your toes. Now sometimes I can, but I don't know if you can tell from the video. I have very short legs, so it's kind of not fair. Okay, I'm not playing fair that way. 4 more. 4, 3, 2, and sit up tall, hands out front, clasp them together, turn to the right, turn it, and middle. Again, you got a nice long lever, left, shoulders, starting to get a little involved, feeling a little bit of heat there, and that is okay. That's what we want, yes? Twist it, middle, good. Twist. You got it, guys. I told you I was counting. I'm still counting. Haven't stopped. I'm getting us there. Middle. Twist it. Pulling your belly button in. Making sure you're breathing. All these things. Kind of a big deal. Give me 4 more. And middle. 3. Okay, here's 2, and last one. Now, this one is a good one. I like this one. I'm going to cross my hands here. I'm going to lean back to touch the back of my chair. Watch me from the side real quick. My body is going to stay in a straight line. Yes? I'm going to lean just like this, and I might not even tap the chair all the way. You could, but you're going to use these muscles to bring you back up, and you're going to keep that body nice and upright. Ready? Here we go. Tap and lift. Good. Tap. I'm going to stay this way. Different perspective. Nothing wrong with a different perspective, is there? Of course not. Sit it back and lift. You're going to let these muscles do the work. Spine is nice and stacked here. Shoulders are not rounded. No, they are not. Breathing. Still smiling. Good, me too. Couple more, guys. Pull that belly button in. I would like 4 more, please. 4 more. Sit it up. Here's 3. And up. 2. And lift. Tall. Last one. Now, we're going to keep this lean, but you're going to take your right shoulder back toward the chair, middle, left shoulder back. Yes. Twist it and lift it and twist. Remember, it's like you're turning a little wash rag at the center. Yeah? Nice and tall. And if your arms are getting tired, set them down. Okay? It's okay with me. You will not hurt my feelings. But I need good form. Gotta have you here. Gotta have you nice and stacked up tall. We got a couple more. Back. I'm sweating. Again, just in case anybody wants to know. I know. 4 more. 4. And up. There's 3. Yeah, give me 2. And lift. Last best one. All right. back to you so I can see from the front. 2 hands together, feet wide. Make a big circle, churn the butter. Bend those elbows in. Yep. Let that core do the job here. Nice and tall. Right? That's all you're doing. Couple more. Good. Reverse that circle. Push and turn. What else is happening? Shoulders. Nice big reach. Let that core make a little circle, a little rotation on that. Give me 4 more. Push. 3. Yes, 2. Last 1. Woo, bring it down and lift. Hey, good stuff. Bring it down. Roll the shoulders back. They help you with all these. Beautiful. Roll them front. Core success, guys. Core success. You gotta have strong core, don't you? Take your right shoe up, lean it. A little bit of a lean, and that's gonna stretch out behind that low back when I'm leading with my chest. All I'm doing, pressing. That's it. Back is nice and straight. Switch heels and lean. Just lean. That's all. Little press. Feel that hamstring and right behind that low back. Those muscles right there. Yes. Sit up. Take your right hand on your left knee. Sit up nice and tall. Give yourself a little twist. Deep breath in and exhale it out. Other side. Here we go. Twist it. Bring it to the middle. Lift it up. Exhale it out. Good. Great job. You can do that anytime you want. Just a couple minutes to get to a strong core. That's all you need. Who knew? Have a good day.
Northwestern Medicine is sponsoring the Aging Brain today. Northwestern Medicine has over 4,000 doctors in Illinois. They're the #1 rated hospital in Illinois, and they have over 33,000 employees to help us get healthy. Please welcome Dr. Monica Gavran, internal medicine with Northwestern Medicine, speaking on the aging brain.
Hi, I am Dr. Monica Gavran. I'm an internal medicine physician, part of the regional medical group, Northwestern in Woodstock. Today, my presentation is related to the aging brain. As the world's population ages and people live longer, the changes in the aging brain present substantial challenges to our health and society. With greater longevity come age-related diseases, many of which have direct and indirect influences on the health of the brain. Although there is some degree of predictable decline in brain functioning with aging, meaningful cognitive decline is not inevitable and is perhaps preventable. I will present the case that the course of aging-related brain disease and dysfunction can be modified. We will go over the risk factors that might contribute to cognitive decline and dementia, and for intervention that might mitigate their impact on cognitive functioning later in life, or even prevent them and their cognitive sequelae from developing. The objective of today's presentation is how aging affects the brain, the differences between normal brain aging and pathological brain aging, identifying risk factors for brain aging diseases, understand different ways to reduce the incidence of the brain aging diseases. Let's go to brain basics. So the brain has two sides, the left and the right. They are called the hemispheres. Each hemisphere has 4 sections, one in the front, one in the back, and 2 in the middle, stacked on top of each other. Each lobe is affiliated with a certain set of function. The lobes are not independent. The brain imaging studies have shown that multiple parts of the brain are active at the same time during any given task. The front lobe, aptly called the frontal lobe, just wait, they are not all named with as much common sense, is the most advanced area of the brain. It received information gathered through the senses and spatial awareness, and is in charge of planning short-term memory, understanding abstract ideas, inhibiting behaviors that might be emotionally or socially inappropriate, voluntary movement, and expressive language. The lower middle lobe, called the temporal lobe, plays a major role in hearing, understanding language, memory, and learning and retaining information. It includes the hippocampus, which involves with forming long-term memory, and I will be mentioning that throughout my lecture. The parietal lobe, it's involved in perception, making sense of the world, arithmetic, and spelling. Occipital lobe, the farthest to your eyes, but important to your vision. In normal versus abnormal aging, the speed of thinking is affected. Attention control. Abnormal brain aging is pathological. On the left side, we have a healthy brain. On the right side, we have the severe Alzheimer's disease brain, which shows atrophy, so shrinkage. It shows an enlargement in the ventricle, the middle dark part in the middle of the slide. During normal aging, we have difficulty recalling names and numbers, difficulty remembering appointments, difficulty multitasking, difficulty learning something new, and that is all considered normal. A steep decline in aging curve, as seen in the chart on the right side, is pathognomonic for dementia. During brain aging, we are developing brain mass shrinkage. The frontal lobe and the hippocampus, they start shrinking at age 20, but by age 60, it's visible. Cortical density thinning is also happening. And the brain has a gray matter and also a white matter. 40% of the brain is gray. It's under the skull area, darker. It's where the processing goes on. 60% of the brain is white matter, the whiter part on the scan on the right side, which allows the different gray areas to communicate with one another. If the gray matter is the factory, the white matter are the trucks that communicate between those two factories. There's a protein which is called beta amyloid that has a tendency to kill the neurons, and that's what causes the brain shrinkage. In myelinated nerve fibers that are shrinking with age causes the slower processing and cognitive function is reduced. There's also neurotransmitter system, decrease in dopamine, acetylcholine, serotonin, and norepinephrine activity, which causes decline in memory and increases the risk of depression, which is felt to be the first symptom of memory impairment and dementia. There are individuals over the age of 80 that they are resistant to normal rate of decline. So studying superagers is the key to help slow the aging process. Northwestern has published a study related to superagers, which showed that they are not developing brain atrophy. When we have abnormal brain aging, we have severe and rapid decline in the cognitive function, memory, and thinking, as shown on the slide on the right. We have difficulty expressing oneself in conversations. We have decreased ability to solve common problems. We have motor system impairment, falling, tripping, trembling as in Parkinson's. The differences between a normal brain aging and Alzheimer's disease can be shown on this slide. In normal aging, we can make bad decisions occasionally, but in Alzheimer's disease, making repeated poor judgments and decision is the norm. Missing a monthly payment is normal with aging, but problem taking care of the bills, balancing your check is suggestive of dementia. Forgetting which day it is and remembering it's later, it's normal in aging and normal aging. But losing complete track of the date and time of the year is abnormal. Sometimes forgetting which word to use is normal. It's on the tip of your tongue, but just cannot come up fast enough. But trouble having a conversation, it's part of Alzheimer's disease. Losing things from time to time, it's normal, but misplacing things often and being unable to locate them, like placing your keys in the refrigerator, it's part of dementia and Alzheimer's or other neurodegenerative condition. In brain aging diseases, we have mild cognitive impairment, and we do have other dementias, which are Alzheimer's, Lewy body, vascular, frontotemporal, and Parkinson's disease. Dementia comes from the word de, without, and mentia means mind, so without mind.
Dementia is a subset of symptoms that can be caused by diseases like Alzheimer's, frontotemporal dementia, Lewy body dementia. There are at least 50 conditions associated with dementia. HIV, Creutzfeldt-Jakob disease, which is caused by prions, it's mad cow's disease, severe depression, head injuries, Huntington's chorea, a genetic disorder. We will not be touching on those. The more common conditions I'm going to try to touch for a few slides. Mild cognitive impairment means memory decline is noticeable to others, but not to the point that interferes with your daily life. So with things that we call activity of daily living, bathing, cooking, dressing, transferring. So those are not impaired. Many times, those changes can be reversible, and checking your vitamin B12 level, treating your depression, stopping some of the medication like anticholinergic medication that we use for incontinence, which is very common in aging, can reverse this condition. But up to half of the people affected could develop Alzheimer's disease within 5 years. Alzheimer's disease is the most common progressive brain disorder. 1 in 9 adults 65 or over develop Alzheimer's disease. It affects 5 million Americans today. The number of patients with Alzheimer's disease will double by 2050. Actually, is estimated to be over 13 million. It's the 6th leading cause of death in the United States, according to the CDC. There are multiple risk factors associated with the death: age, family history, genetics, history of head trauma, midlife hypertension, obesity, diabetes, hypercholesterolemia. We will be going on more in details in the next slides. The cause of Alzheimer's disease, it's felt to be oxidative stress and inflammation. We have heard this word repeatedly on the TV lately. Inflammation is caused by unhealthy food consumption, smoking, pollution, viral infections, chronic illnesses that break up the blood-brain barrier. The changes in the brain with Alzheimer's disease are related to buildup of amyloid beta protein, neurofibrillary tangles, which cause neurons to die. There's loss of synapses, and the brain tissue shrinks. I would like you to imagine the brain as a painter canvas. On that canvas, you have smooth stars. Those are the neurons. Those stars are connected by lines, and then you have the clean canvas in the background. Using this analogy, the changes of the brain with Alzheimer's show a buildup of amyloid beta lipoprotein in between the neurons. So that would look like splotches of unwanted paint on the clean canvas. We have neurofibrillary tangles, the tau proteins, that they form inside the neurons. It's almost like excessive paint inside the stars. So that makes the canvas raised, uneven in texture. The neuron die off, like you wash away some of the stars. You have the loss of the synapses, the gap between the neurons that they require for communication. So the line between the stars will disappear. And then you have the brain tissue that shrinks, atrophy. That's what we call brain shrinkage. And that would look like you put the canvas in the dryer. So the resulting canvas is a lesser version of the original.
There are a few stages of Alzheimer's disease: mild, moderate, and severe. The duration is on the slide. Usually it's 2 years, but can be even longer. The disease usually starts in the medial temporal lobe, and short-term memory loss is the first symptom. Spread to the lateral temporal lobe and the parietal lobes, and you have problems with reading, poor direction sense, you forget where the grocery store is or which aisle you always bought sugar, poor object recognition. Moderate Alzheimer's disease, it spreads to your frontal lobe, and that's when your behavioral problems start. Your poor judgment, impulsivity, short attention span. In severe Alzheimer's, the disease spread also to the occipital lobe, so your symptoms start including visual issues. Lewy body dementia is the second most common type of progressive dementia after Alzheimer's disease. There are protein deposits called Lewy body that develop in nerve cells in the brain region involving the thinking, memory, and movement. There are no specific causes yet to be identified for Lewy body dementia. Symptoms of Lewy body dementia are changes in thinking and reasoning, confusion and alertness that vary significantly from one time of the day to another. A patient can wake up confused and be perfectly normal by the afternoon or the other way around. Slowness, gait imbalances, tremors, and frequent falls are prominent in Lewy body. Well-formed visual hallucination, seeing children, pets, delusions, false beliefs are very common. Trouble interpreting visual information, sleep disturbances, acting up in your sleep, falling off the bed, thrashing around during sleep, malfunction of the autonomic nervous system, passing out when you stand up, having severe constipation or diarrhea, memory loss that may be significant but less prominent than in Alzheimer's. Vascular dementia is a general term describing problems with reasoning, planning, judgment, memory, and other thought processes caused by the brain damage from impaired blood flow through the brain. The risk factors of vascular dementia are common risk factors for heart disease, such as diabetes, high blood pressure, high cholesterol, and smoking. Symptoms again include confusion, disorientation, poor judgment, difficulty with your speech. Frontotemporal dementia affects the lobe of the brain that's behind your forehead. It's a group of brain disorders. There's a behavioral variety. There's a primary progressive aphasia that affects your language. And then there's a disturbance of motor and movement muscle function. It's the most common form of dementia for people who are under 60 years old. Primary progressive aphasia, people have difficulty with word usage, word order, word finding, spelling, and comprehension. In corticobasal syndrome, usually share some of the symptoms of Parkinson's disease, starts around age 60. People have significant tremor, rigidity, and slow movement, but memory impairment, it's more severe. Progressive supranuclear palsy syndrome. It's a neurodegenerative syndrome that causes dementia and also problems with movement. People have a tendency to fall backwards. They have frequent falls, especially when they look up trying to get something from a cupboard. Abnormal eye movement, change in behavior, change in speech, change in language. Usually it begins in early 60s, but we need to be aware of that in early 40s in people that they have frequent falls. Posterior cortical atrophy is also a neurodegenerative syndrome, affects the back of the brain, the occipital region, which is responsible for processing visual information, difficulty with vision, inability to read or write. There is a visual representation of what the vision of a person with PCA looks like in the slide. Parkinson's disease. We will not spend a lot of time, but usually begin gradually and get worse over time. Parkinson can be complicated by memory impairment. The symptoms of Parkinson's are tremors, stiffness of the limbs and trunk, slowness of movement, impaired balance and coordination, sometimes leading to falls. Let's talk about the risk factors for brain aging diseases to see how we would be able to modify those. An overview of risk factors for brain aging is on this slide. So weight, obesity especially, high blood pressure, high cholesterol, genetic risk factors, low social participation, isolation, depression, binge drinking and alcohol, head trauma, hearing loss, and sleep disturbances. They all have been linked with development of memory impairment. Weight. Obesity, high cholesterol, and high blood pressure significantly raise the risk of Alzheimer's disease. A combination of all these three factors will increase the risk for Alzheimer's by 6-fold. It's not just obesity, it's the deposition of fat in the mid-abdomen. So a woman who's apple-shaped, even if it's not technically overweight, would have a higher risk of Alzheimer's disease secondary to insulin resistance. The greater weight is linked with lower brain volume. Inflammation is thought to be causing all these changes. Inflammation is linked with heart disease, and everything that increases our risk of heart disease will increase our risk of dementia also. Risk factors for brain aging, high blood pressure. High blood pressure sets the stage for memory loss. National Institute of an Aging study found that people in their mid-50s and older with high blood pressure scored lower on memory tests than people with normal blood pressure. There is more correlation with blood pressure in your middle age than later in life. Over the years, the goal for blood pressure has been lowered. 30 years ago, normal blood pressure was 100 plus your age. So if you were 80 years old, 180 was considered normal. Then later on, 140 over 90 was considered high blood pressure. And over the last 3 years, high blood pressure is defined as a blood pressure above 130 or 80. Lowering the prevalence of high blood pressure by 25% could significantly reduce the incidence of Alzheimer's disease by nearly 100,000 cases a year. High blood pressure, I would say, it's the easiest risk factor to control. We have medications, lifestyle changes, and we would be able to significantly change the trajectory of a patient. There are certain blood pressure medications that they are brain penetrant, and lately ACE inhibitors, medication that start with IL, lisinopril, captopril, or ARBs like losartan, valsartan, were linked to better memory recall. And this research was lately published in hypertension. So even the medication that we prescribe for hypertension is important. High cholesterol. High cholesterol levels may increase the rate of plaque deposition. Elevated cholesterol level have been linked in some studies with increased risk of Alzheimer's disease. Genetics. A parental history of dementia is associated with approximately twofold increase in the relative risk of dementia and Alzheimer's disease. Risk declines with advanced parental age at diagnosis. There's little to no increased risk when a parent is diagnosed after the age of 80 years old. Many patients have been checking their ancestry and sending out kits to 23andMe and found out that they have the ApoE4 gene. That does not mean that you will have dementia. You can do lifestyle changes and change your destiny. Social isolation. Social isolation, I think that it's an easy fix also. It's a risk factor not only for dementia, but also for hypertension, coronary heart disease, and depression, according to a 2017 study published in National Library of Medicine. Low social participation, fewer social contacts, and more loneliness have all been associated with increased dementia risk. Social isolation many times leads to depression, and also alcohol consumption is increased. A history of depression is associated with an increased risk of dementia, and in a heavy drinker, you can see on the slide the percentage of frontal brain shrinkage is much bigger than somebody who is an abstainer. Many times depressive symptoms can be an early manifestation of dementia. That's the reason why treatment is advisable. Alcohol abuse is associated with cognitive dysfunction based off a report from Journal of Neurology, Neurosurgery, and Psychiatry, especially binge drinking. Small amount of alcohol, as I will present in the next few slides, can have a protective effect, but not large amount of alcohol, which would be considered more than 2 drinks a day in a patient who is 65 and over. Another risk factor is head trauma and hearing loss. Repeated mild head trauma can result in chronic traumatic encephalopathy, which can have similar symptoms as Parkinson's disease. So using a helmet and prevention of head trauma early during childhood sports is advisable. Peripheral hearing loss may be also a risk factor for the development of dementia. It is an independent from age and other factor. Individuals with baseline hearing loss have increased risk of incident cognitive impairment than those without. Mild hearing loss, 2 times more likely to develop dementia, and severe hearing loss, 5 times more likely to develop dementia. Medicare at present time for patients over 65 will cover hearing testing, which I definitely would recommend in anybody who is experiencing hearing loss. Sleep. Lack of sleep leads to obesity, diabetes, heart disease, increased inflammation, weakened immune system, and directly impacts brain. Sleep consolidates memory. During sleep time, our lymphatic system, it's our waste disposal in the brain, gets rid of the beta amyloid, which, as mentioned earlier, has a tendency to kill our neurons. One night of bad sleep reduces beta amyloid clearance. Sleeping on your side, it's most effective in clearing beta amyloid. Maybe because it helps if a patient has obstructive sleep apnea. Anything that decreases blood oxygen saturation at night increases the risk of age-related neurodegenerative diseases, including obstructive sleep apnea. Insufficient sleep and sleeping longer than average have been linked to a greater likelihood of developing dementia. Prevention of brain aging diseases. This is the most important thing. I hope everybody is still listening. Now it's the time to take some notes. How do we prevent brain aging diseases? Well, it's again exercise, it's quit smoking, it's reducing stress, it's dietary changes like the MIND diet, and preventing head injury, supporting your mental health, keeping your brain active. Exercise is very beneficial. It helps maintain your healthy BMI, reduces insulin resistance and blood pressure, and reduces risk for heart diseases and stroke. For adults age 65 and over, we recommend 150 minutes or more of moderate intensity aerobic activity per week, or 75 minutes or more vigorous intensity aerobic activity per week. Researchers by the University of Miami in Florida found that individuals over the age of 50 who engaged in little to no exercise experience a decline in memory and thinking skills comparable to 10 years of aging in 5 years, compared with those who took part in moderate or high intensity exercise. Physical activity slows brain aging by 10 years. Dancing. Dancing may also have an anti-aging effect on brain. A study by the German Center for Neurodegenerative Disease in Magdeburg found that regular exercise can reverse signs of brain aging, and the most profound effect was among people who danced. Maybe because they socially interacted, they had to learn a new movement, and they listened to music at the same time. Physical exercise can improve cognitive ability, and it's associated with boost in the hippocampal volume. Functional MRIs were able to show that in follow-up studies. For those over age 65, adding 2 to 3 strength sessions to your weekly routine can cut your risk of Alzheimer's disease in half. Exercise does not have to be sitting on a stationary bike. You can take a walk. You get outside and walk with your dog, walk with a friend, mix up your exercise and have fun. Sleep, as mentioned earlier, is very important to overall health, and lack of sleep can lead to obesity, diabetes, heart disease, weakens your immune system. These conditions are bidirectional and also impact your brain health. Obstructive sleep apnea is an important risk factor for Alzheimer's disease. It's critical for everyone with cognitive decline and memory problems to check their oxygen level and ask your primary physician if your levels are dropping less than 96% to refer you for a formal sleep study. Snoring, stopping breathing are other signs of apnea. Getting a good night's sleep is crucial for preventing brain aging diseases. How can we improve that? We keep a regular sleep schedule. We set a sleep goal, at least 7 to 8 hours. You limit your caffeine After lunchtime, refrain from alcohol before sleep. Alcohol is a stimulant. Stay away from the nightcap. Don't exercise within 3 hours of bedtime. Wind down, refrain from stimulating activities several hours before sleep. Block the blue light. You can use glasses. Stay away from your laptop and phone for at least 2 to 3 hours. No TV in the bedroom. I know that's hard. Make your bedroom a sleep sanctuary. Keep it colder, 65 degrees. Or also use some alternatives. Many times I get this question, what can I take for sleep? I cannot sleep. Can I take a medication? There are other modalities to help with sleep. Things like lavender oil, chamomile tea, magnesium threonate, improves cognition and also has sedative properties. There are some herbs which are called adaptogen, ashwagandha, bacopa monnieri, that can be used. Use of benzodiazepine and other sleeping medication increases your risk of fall, which increases the risk of head trauma. A good book to read, it's called Why We Sleep, and it's by Matthew Walker. Another way of preventing brain aging diseases is by smoking cessation. Observational studies from the Journal of Cognitive Vitality have shown that people who smoke are at a high risk of dementia, and there's almost 80% increased risk for Alzheimer's disease. The World Health Organization guidelines strongly suggest quitting tobacco use since it may reduce the risk of cognitive decline. They suggest a combination of both behavioral and pharmacological approaches, and we do have medications like nicotine patches, which actually at present time are studied for prevention of dementia, and the new medication Chantix. How to prevent brain aging diseases? Social engagement. A study published in the International Journal of Gerontology concluded that positive social interaction could help prevent dementia. Specifically, the study indicated that elderly people engagement with the social environment and in social activity would prevent it. A different study showed that people that participated in discussion groups have improved cognition function and also increased brain volume according to MRI. Stress. We can change the way we react to stress. Unfortunately, we cannot change our stressors. Stress ages the human body. Therefore, preventing or managing stress has an anti-aging effect. Some stress reduction strategies are mindfulness, meditation, prayer, exercise, avoiding multitasking, and trying to build stress reduction into your schedule. Mindfulness means fully being present in the current movement. It creates awareness, stops negative feedback loops, and resets your response patterns. Deep breathing stimulates the vagus nerve, which helps to induce a relaxation response to stress. An exercise for deep breathing would be sitting upright, inhaling through your nose slowly on a count to 4, hold to the count of 4, exhale slowly through your mouth to the count of 4. Works much better than Xanax. Brain stimulation. Brain stimulation can grow, shape, and rewire our brain. Never stop learning. People with a higher education are less likely to develop dementia, according to a study published in the Journal of American Medical Association. Learn to play a musical instrument. People who have learned to play a musical instrument have reduced risk of cognitive decline as they age. Familiar music from decades ago provides the soundtrack for the replay of forgotten memories. It's shown to decrease your cortisol level and enhances estrogen also. Turning off your TV and listening to your music enhances exercise. It helps with your household chores. You can ask my children. On Saturday, I ask Alexa to play Edith Piaf, and my children know that I'm cleaning the house. It also helps with your workout. Try to learn a foreign language. Lifelong bilingualism may increase reserve and delay onset of dementia between 4 and 5 years. Doing puzzle, Sudoku challenges your brain and increases your brain function. Music listening offers cognitive benefits and stimulates deep neural connection. Nurturing what excites you offers powerful neuroprotective effects. The Mind Diet. The Mind Diet is a healthy, evidence-based way to eat, and it's designed to help prevent Alzheimer's disease and delay cognitive decline. Researchers from Rush University and Harvard University developed the Mind Diet. It stands for a Mediterranean and DASH intervention for neurodegenerative delay. It takes the best brain health components of both the Mediterranean and DASH diet. It's less demanding. It's made up of 15 components, including 10 brain healthy food types to consume and 5 brain harming ones to avoid. It works because through evidence-based research, the antioxidant-rich and anti-inflammatory foods that they were chosen and removal of the brain-harming foods may be just as, if not more important, that those foods on that list directly harm the blood-brain barrier and promote the formation of damaging beta-amyloid plaque. Those 5 food groups include red meats, butter, sweets, cheese, pastries, and fried foods. The Mind Diet was shown to decrease the risk of Alzheimer's disease if followed by 53%, and even if partially followed just by reducing the 5 food group by 35%. The 10 healthy food groups are berries, which should be consumed at least 2 times a week, whole grains 3 times a day, fish just 1 time per week, nuts, snack on most days, beans, leafy vegetables, chicken and turkey 2 times a week, and olive oil. The study showed that the more closely the Mind Diet was followed, the bigger the benefit, 53%. The effect of the Mind Diet was independent of the other healthy lifestyle choices or cardiovascular related condition. This is an example of a Mind Diet plan. For example, for breakfast, 1 slice of whole grain, bread with 1 tablespoon of peanut butter and a sliced banana, 3 ounces of pork tenderloin, large spears of grilled asparagus, 5 ounces of red wine. Yum. Supplements. Supplements are not replacement for healthy eating and exercise. They serve to enhance the benefit derived from healthy lifestyle choices. The Global Council on Brain Health concludes that because supplements are not regulated by the FDA, there's no way to know exactly what is in them, so they do not recommend them. My stance is a little bit different. I think that there are some risk factors that can be modulated by using supplements, like high homocysteine, systemic inflammation, insulin resistance, deficiency in vitamin D, and poor brain flow. We can reduce systemic inflammation by eating your fish, having your olive oil, ground flaxseed, and nuts in your smoothies. But if you hate all of those, a total dose of 1 to 3 grams of days of omega-3 fat as DHA and EPA can be helpful. It basically showed an association between higher fish oil consumption in a study in neurology in middle age and reduced risk of dementia. If people have the ApoE genotype that are epsilon 4 carriers, those people derive more benefit from fish or omega-3 fat consumption than non-carriers. Curcumin and ginger are shown to decrease systemic inflammation. So if you don't like curry, then using 1 gram of curcumin can be also beneficial in preventing inflammation. Increasing insulin sensitivity. 1/4 teaspoon of cinnamon a day, that's all what you would need. But zinc picolinate, chromium picolinate, 500 milligram twice a day, increasing daily fiber can also improve glucose control. Optimizing your microbiome. Your gut microbiome is made of trillions of microorganisms that live in your intestinal tract. These microorganisms, they are bacteria that are involved in functions critical to your health and well-being. These bacteria, they have a key role in digesting the food you eat, and they synthesize the nutrients also. They have an important role in immune regulation as well as in your brain function. There are direct correlation between your gut health and obesity, also anxiety, depression. So eating fermented foods like kimchi or sauerkraut, if you have a German origin, having your yogurt or kefir or kombucha is the way to go, but sometimes people have added some over-the-counter probiotic, slippery elm extract, probutyrate, and lignite extracts. Vitamin D essential. It mediates the transcription of hundreds of genes by which it affects critical processes such as neuroplasticity. Vitamin D deficiency has been associated with cognitive impairment and a higher risk of Alzheimer's disease in older adults. Vitamin E for prevention is not recommended, but if a patient has established mild to moderate Alzheimer's disease, in a study in JAMA in 2014, 2,000 international units was found to be beneficial in slowing the progression. Multivitamins, aspirin were found to be ineffective in preventing cognitive decline. Vitamin B supplementation, B6, B12, and folate are found to lower serum homocysteine level, which is associated with impaired cognition. A homocysteine level should optimally be less than 7 micromolar. Lowering homocysteine can be achieved by using 1 milligram of vitamin B12, 0.8 milligrams of methylfolate, and 20 milligrams per day of vitamin B6. Too much vitamin B6, though, can cause nerve damage, neuropathy, and numbness in your extremities. Other preventive therapies, statin medication. Controversial, many of my patients do not want to take them, but they are used to lower your LDL level, but they have anti-inflammatory properties. They reduce amyloid burden by decreasing inflammation. They also work indirectly by decreasing your risk of stroke. If people take statin medication, I recommend them to use coenzyme Q10 or its reduced form ubiquinol, dosage anywhere between 90 to 200 milligrams. Also, to help with the aging process. Resveratrol, I prefer the grapes or a glass of wine, but some patients would benefit from using a supplement. A preliminary study in Annals of New York Academy of Science showed promising results and resveratrol ability to increase synaptoblastic signals we want for cognitive support. Ginkgo biloba, which many of my patients have taken, has no effect on reducing the incidence rate of dementia and Alzheimer's disease. So, all that being said, it's very important for us to detect these neurodegenerative conditions early and diagnose them. They ensure quality care and planning to combat dementia. We ensure that the patient is heard and treated. We encourage people to seek help regarding dementia. Go and get your Medicare wellness every day. Your physician will do a mini COG exam, and if there are issues, they would be able to address them. The last word on healthy aging: avoid saturated and trans fat. Most of what you eat should be vegetable, legumes, fruit, and whole grains. Eat food, not supplements for vitamin E. Find a good source of vitamin B12 every day. Walk briskly for 40 minutes every other day. Avoid aluminum in cookwares, antacids, baking powder. Positive social activity, attending the theater, sporting events, travel with a group of friends, visit family and friends now, serve meals at the soup kitchen, volunteer at the local animal shelter, school library, or hospital. Stimulate your mind. Take cooking, art, or computer class. Form or join a book club. Learn how to play a musical instrument. Play cards, games with a friend. Sing in a community choral group. Find purpose. Nurturing what excites you offers powerful neuroprotection. Although much work remains to be done to meet the challenges of the aging brain, strategies to promote its health have been demonstrated and offer much promise, which can only be realized if we mount a vigorous public health effort to implement these strategies. Thank you very much for your time.
Well, hello there.
Hello.
Thank you for spending some time with us today at our expo. We appreciate it. It was a lot of content. It was very good.
Yeah, a little bit too much.
Well, it depends who you talk to and what capacity they have, right?
Right.
So the aging brain, I have one of those. There's a difference between normal aging and a brain with dementia or Alzheimer's or some sort of capacity issue. So when we're aging and we're forgetting words and we're forgetting people's names, is that a sign of dementia, or is that just normal process of aging?
It's just a normal process of aging. So no, definitely that is not considered an abnormal part. Going in a room and not knowing why you went there, still normal.
Really?
Yeah. still normal, but asking the same question over and over, it's not. And sometimes you would think like, oh, you know, that's a normal thing, but that's actually a sign of brain damage. Going into Jewel and trying to find where hot chocolate was before and not finding the aisle. And for the last 20 years, you were buying hot chocolate from that aisle. And wandering in Jewel for half an hour without asking somebody where that is, that's an abnormal behavior. So.
Ah, well, that's good. Well, at least I have hope because I'm forgetting everything lately. It's probably because I'm very busy, I'm guessing. So is there, in terms of the last year and a half, because of the isolation in our older adults, have you found that there's been a lot more cognitive impairment popping up or because of the isolation?
Yes, I have. So also, I think that depression, which is a precursor of memory impairment, has been rampant over the last half months and so. And I think that even right now, when things are opening up, people are still worrying about getting out of their home or not getting infected. And so I think that it's a continuum. It's not just it has happened. So any type of interaction that we can have with our elderly or with our friends and checking on them through Facebook or any other means, I think that it's important. Preventing dementia through exercise. So you can walk around your neighborhood, you can walk around your apartment, you can dance when you vacuum with your vacuum cleaner. So those are all important parts of preventing depression, secondary to isolation, and also treating and preventing dementia. There was an interesting study in people with Parkinson's disease that if the physical therapist put on the music that they enjoyed, they were able actually to move much easier than if they would just do regular physical therapy.
Really?
Anything that we can employ, you know, any form of activity, music, because it's a possibility that this pandemic will continue and we will see maybe the fourth wave. So we need to kind of prepare for that emotionally. And I believe in the power of now. So sometimes not worrying about what's going to happen tomorrow and trying to live every day to the fullest. I think that it's the thing that I would recommend in general people.
I love that. I love the power of now.
Yes.
That's fantastic. I'm using it. You didn't trademark it, right?
No.
Okay. Okay. So I agree. Music is very good for the soul. So for those who are isolated or are going to be isolated again, the things they can do, 3 top tips would be stay active, stay engaged.
Yes.
And
engage. And also, I think that the power of prayer and mindfulness, I think that is very, very important. So there are different type of free apps like Let's Meditate that people can download on the Facebook or any other ones, which also are very, very effective ways of decreasing our anxiety.
Oh, my daughter does that. I can't sit that long, but she can.
My son loves Headspace. He likes people with the British accent. So.
Oh yes, my daughter pretends she's British. It's very funny. It is very humorous. Anyway, thank you so much, Doctor, for being on today. We do appreciate your time. We know you're very busy, and appreciate all you do for our seniors.
No problem. Thank you very, very much.
Take care. Bye-bye.
Are you ready for a fun game? The Brain and You. Sarah Moore, Director of Community Relations with Revere Court, is our host today. This brain game will make you think hard so you can win a lot of prizes.